Do you want to use this couple of minutes to just have a quick roundtable about a potential second meeting?
Oh, yeah. So we were discussing a little beforehand, sort of what we want to do going forward. So far, we've enjoyed this meeting quite a bit. So, we're going to do this next year probably. So
hope you enjoyed it as well, guys.
Yeah. So, with that in mind, probably next year will also be virtual. I mean, there's actually a lot of benefits to having a virtual conference, as it turns out. I think it worked really well. I think having recorded speakers is good because it means speakers get to see the sessions in the, they get to see the other people in the sessions that they're in, which are probably the most interesting to them because they're not nervous about their talk. But also it's great because it means that pretty much anyone can attend. I mean, it doesn't really cost anything to attend. You don't have to go anywhere. So keeping the conference virtual might be a good thing. On the other hand, there's advantages to being in person. So maybe some years in the future we might want to try to do something in person. But I think if we do that, I think we were having some discussions. I think we really want to keep virtual attendees as first-class citizens of the conference. Make sure that they'd be included in everything because. Some people, it's impossible for some people to attend, and I think we benefit from having a wider group of people discussing these things. It adds a lot of flexibility. So, if anybody has any suggestions, you can DM us. You can put them in the. I think you have most of our emails. I think there may be a feedback form on the website. Is there? I don't recall.
Not yet, but we're planning on making one.
Yeah. Yeah. So I mean, having it virtual and having it free has great advantages. We have a. Yeah.
David,
yeah, I agree. Pre-recorded talks means the speakers can enjoy the conference, and that was certainly true for me. Usually in the sessions I'm in, I'm just sort of sweating and thinking about my talk and not paying any attention whatsoever to the other speakers. I like not having to do that.
I think this format's nice for what it's worth.
Okay. Yeah, I mean, it seems to work pretty well. Okay, so where are we in terms of time? Okay, it's 5 past the hour. I think people who want to be here are here. So why don't we start the session? So we have.
I think that question comes actually up a lot if you want to answer that.
Oh, when would the talks be available online? Yeah. Well, I think the answer we've been giving people is probably in a week or two. I'm not sure what issues there are that we need to resolve, but I think we need to, we need to stop the conference bit and then think about what we need to do to put them up. Probably going to put them up on YouTube. And I think we just need to get everybody's permission to make sure that we do that. Which I think for some, we pretty much have. Oh, by the way, I'm also stating this meeting is being recorded as we speak. I think we need to say that at the beginning of every session so people know that if they want to participate. And we are planning to distribute the video. So, probably a week or two, maybe less, depends on how long it takes us to do it. Okay, so without further ado, I think we're going to start with our first speaker. Our first speaker is Dr. Molly Bright, who you've heard on the panel. Following a BS in physics from MIT, Molly received her DPhil from the University of Oxford as part of a collaboration with the U.S. National Institutes of Health, working with Peter Jozard at the Oxford Center for Functional MRI of the Brain, FIMRIB, and Jeff Doyne at the Advanced MRI Group of NINDS. She completed a postdoctoral training with Kevin Murphy at the Cardiff University Brain Research Imaging Center, Kubrick, and then moved to Nottingham as an independent Anne McLaren Fellow, developing ultra-high field MRI imaging methods for the study of cerebral physiology at the Sir Peter Mansfield Imaging Center. In 2018, she joined the faculty of Northwestern University in Chicago, where she is now an assistant professor of biomedical engineering and physical therapy and human movement sciences. Her group, the Applied Neurovascular Imaging Lab, develops and translates neurovascular MRI techniques to study neurological disease and rehabilitation.
Hello, my name is Molly Bright. I'm an assistant professor at Northwestern University, and I'm speaking on hemodynamics and vascular reactivity. I run the Applied Neurovascular Imaging Lab at Northwestern. We're based in downtown Chicago and are really trying to take neurovascular imaging methodologies and translate them clinically to study pathology and rehab. So an outline of what I'll speak about, what is cerebrovascular reactivity? I'll orient us as to what is CVR. I'll touch on how we might be able to access that from resting state data. But I'll very quickly jump to why I like to vary breathing in the context of fMRI. I'll give you some examples of how our physiology really is very interconnected and what that might mean, particularly how it leads to some intriguing spatial patterns that we see when mapping CVR. So with that, what is cerebrovascular reactivity? It's a big umbrella. So cerebrovascular reactivity is the response of vessels to some type of vasodilatory stimulus. And actually, I'll correct that and say vasoactive stimulus because some might constrict as well as dilate our vessels. But when you're doing a CVR experiment, you need a stimulus and you need some imaging modality. You'll see a lot of acetazolamide work, particularly in clinical literature, but I think these days it is most common to see inhaled carbon dioxide challenges. Carbon dioxide is a very strong vasodilator, and it can be kind of manipulated to reverse the effects and modulate it in real time and repeat this in an experiment. So it's pretty much become the primary methodology in CVR mapping. In terms of imaging, you have many possible candidates, but again, for today's talk, thinking about the interests of everybody in the audience, I am going to focus on bold fMRI as fMRI really creates and represents the most diverse spectrum of physiological information. So for today, I'll be focusing on bold. And in general, we could try to measure two aspects of CVR. We can measure the amplitude of this dilation response, and we can measure the latency of that dilation response and try to gain insight into vascular health and function through those two parameters. Thinking about CVR amplitude, it's not really a linear system. At some point, your vessels will not constrict further, and at some point, your vessels will not dilate further, just because your CO2 continues to be modulated. So what we actually have is this type of sigmoidal dose response curve, where your flow has this kind of S-shaped relationship with arterial CO2 levels. And most of the time we are at rest, we're situated somewhere in the middle of this sigmoid, and we modulate CO2 in a small region around that point. And in this regime, we typically assume a linear relationship between this dilatory flow response and carbon dioxide. But with the sigmoid, we might also be interested in how far are we from this upper plateau. There are several pathological conditions where you might have this compensatory vasodilation, and as that occurs, we may inch closer and closer to this maximal dilatory limit. So knowing where we are in relation to that upper limit could also be extremely important. So although these definitions may not be standardized across the literature, and I think many people might use these terms somewhat interchangeably, it helps me to think about this differentiation where reactivity is looking at this type of linear response of flow to smaller changes in CO2, and cerebrovascular reserve, same acronym, unhelpfully, but reserve would be reflecting how far you are from that upper limit. And in terms of units, we want to reflect this flow response to change in arterial CO2, but getting an arterial measure typically isn't feasible. So we usually use an end-tidal CO2 estimate as a surrogate. And you may sometimes see percentage changes in CBF as well. But again, for this talk, I am focusing on using bold fMRI, and so our units will be percentage bold signal change per change in end-tidal CO2, which will be in millimeters of mercury. So this is our, I guess I would call it a semi-quantitative CVR amplitude measure. And it lets us sort of compare CVR longitudinally. It lets us compare it across cohorts. But there are limits to this quantitation, as we all know that bold signals represent very, very complex relationships between flow and volume and metabolism. So there are limits, but that would be our units of quantified CVR amplitude. And with gas inhalation, we can do all sorts of things to our CO2. So we can have long periods of steady state hypercapnia. We can have sinusoids of CO2 delivery. We can have short boxcars, and we can even have ramps that might let us access that sigmoidal dose response curve. But all of these things can be achieved with systems like the one shown here, where I'm looking delighted to be a participant for my lab's research. So that's amplitude. What about lag and delay? We're measuring end-tidal CO2, so that's a reference, and we're trying to understand the relationship between that reference of the stimulus, of this dilatory stimulus, and our bold fMRI time series, perhaps every voxel in the brain. And within that lag, there are going to be many types of delay. So in the first instance, we're going to have measurement delays. We are reliant on an individual to exhale through their nostrils into a nasal cannula, and then there's a long sampling line that will take that signal from the scan room to the control room where our capnograph is situated. So there's quite potentially a long delay from this type of system. We then have vascular transits between the lungs and the heart and the brain, which also must be factored in. And then at the tissue level, there's some local dilatory response that might also have its own delays associated with it. So all of these combine into this one measure of a CVR lag or delay. So we may not really be able to compare the absolute timings of CVR lag across experimental setups, stimulus types, or patient cohorts, but there's still a lot of relative information that we can glean. So there's a rich literature on MRI mapping of CVR. I will point you, for example, to this Frontiers in Physiology sort of special issue or research topic that I was involved with. There's also a book coming out. You might see some familiar names as the editors, but with my esteemed colleague Nick Blockley, we put together a chapter on CVR mapping with MRI that kind of talks you through what I've just hinted at in a little bit more detail. And there's also a rich community of researchers interested in these things. And actually, I'd encourage everyone at this symposium to potentially get involved with the Imaging Cerebrophysiology Network. You can go to icp-network.org for more information. For example, we've recently set up a monthly webinar where we talk about different aspects of cerebrophysiology that can be imaged with MRI. So I think there's a lot of overlap between the interests of that community and the people at today's and yesterday's symposium. So what can we do if we don't want to invest the time and effort and cost and risk of these gas inhalation systems? Is it possible to get at this CVR from resting state data? And the answer is, of course. The information is in there. Typical approaches include things like the amplitude of low frequency fluctuations or the fractional amplitude, ALF and FALF. And I point you to this review led by Joanna Pinto for more information. The information's definitely in there. There are CO2 fluctuations and there are bold signal changes associated with that. But there are challenges in terms of really extracting CVR from this type of scan. And this is my main assertion. Unless we are measuring CO2 changes and incorporating that into our analysis, then anything you can estimate from resting state data loses the scaling and the specificity. So while ALF and FALF and other parameters give you spatial patterns that look extremely similar to CVR maps, I think that it's not necessarily specific, and we aren't able to compare those maps in any absolute way across time or between cohorts. So there's a lot of information there. It's potentially very powerful, but I think it's very important that we develop analysis methods that bring in our understanding of what the CO2 changes are in order to really make CVR estimates that have semi-quantitative units that are scaled appropriately and that are more specific to the CO2 changes. This meeting, if anything, is highlighting how many physiological parameters are at play in our fMRI data. So if we want to talk about CVR in relationship to a dilatory CO2 effect, we need that relationship to be intrinsic to our analysis. How would we do it? It's tricky. So most likely what we're going to do is try to measure CO2 during a scan and put that into some type of model. And Richard Wise, back in 2004, demonstrated that end-tidal CO2, as shown in the top plot, that time series is immediately visible in a bold signal time series shown below. So we can take that end-tidal CO2 data, we can put it into our typical fMRI general linear model and potentially extract the amplitude of this CVR response in units that then have some semi-quantitative meaning. But we want to incorporate lag. We know there is some type of offset between our end-tidal recordings and the bold fMRI time series fluctuations. So we want to know what that lag is and account for it and apply it in our modeling, but actually pinning that down is non-trivial. So here, what I'd like to first draw your attention to are the blue circles. What I did here was plot the optimal shift found via cross-correlation between end-tidal CO2 recordings and the bold fMRI time series. And I split the data in half, the first half and the second half. And there is no relationship between this optimal shift, this hemodynamic lag measurement, when we're using just this resting state data in the blue circles. However, if you have bigger variations in CO2 caused, say, by holding your breath or any type of breathing manipulation, then you suddenly see a good agreement between different portions of our data. So what my take home from this is that resting state data may not have the variability we need to really lock into this timing difference. And so in my lab, I'm looking for something maybe not one of these two extremes, right? You have resting fluctuations where it's difficult to pin down the CVR effects and really understand the timing relationships. At the other extreme, we have gas inhalation, which is a much more complex experiment that may not be necessary. And my lab, well, I like to be about here. And it's not just because, you want to find a Goldilocks point that splits the difference. It's because actually there's so much benefit to be gained by doing a little bit more than just resting state, even though you're not going all the way over to a true gas inhalation CVR experiment. So by this, I mean we want to intentionally vary our breathing patterns to get a better handle on CVR. So one type of intentional variation of breathing would be a breath hold. So here you can see bold signal changes driven by repeated breath holds. Or it might be cued deep breathing. That's a term I made up in my PhD. It hasn't really caught on. You might see paced deep breathing or deep breaths or hyperventilation. It depends. But in both cases, you can derive a bigger bold signal response that might help you more robustly characterize amplitude and delay of this CVR effect. And you can certainly plot amplitude. So how are we going to take the CO2 information and bring it into a general linear model to maintain the scaling and quantification of our CVR amplitude, but also access this latency information? So for that, I will introduce the work of two members of my lab who have proposed adding simple breathing tasks to the beginning of your resting state scan. So you have maybe 8 minutes of resting state, and I'm saying just add something, some type of variability in the very first few minutes. It's a low-cost addition to your experimental setup. And without any fitting at all, you can see a very clear, strong relationship between big changes in CO2 and big changes in your bold fMRI data, showing that CVR effect. So in this little study, we added 3 breath holds at the beginning of resting state. We tried adding 2 sets of deep breathing to the beginning of the resting state, or not doing anything. And we measured end-tidal CO2 in all of our data. And importantly, we measured end-tidal CO2 well before and well after the scan itself. That allows us to shift that information forwards and backwards in time. And we used what I'm going to call a lagged GLM approach to identify the temporal delay of the CO2 effect in our data at the voxel level. So you have your CO2 data, and you have information before and after where your scan is, and you shift that information in small increments. And with each shifted variant, we're going to do a general linear model where we incorporate head motion regressors and any other physiological nuisance regressor you might want to consider. All of it goes into the same model. All of it is accounted for, and our CO2 regressor is the thing that's being slightly shifted and modulated. And in our study, we looked plus or minus 9 seconds. You may want to change that based on who you're looking at. But when we get the shift that produces the optimal model fit, we can then extract fit parameters like this to give us CVR in quantitative units of percentage bold per millimeter of mercury CO2 change. So on the top two plots, you see the CVR maps that we get in without any lag optimization, but in our breathing task data. And in the bottom, you see when we only look at the resting portions. And it's just a lot specklier and noisier when you're dealing with just rest, whereas there's a much more robust mapping of CVR when you've added those little modulations of breathing. And our lag estimates are more robust. So the top row is the lag estimate, which we then threshold for significance, and then a further statistical threshold that accounts for the fact we've done lots of tests. And in the breathing test data, we see this good, robust estimate of lag throughout cortical and subcortical gray matter, showing some of the same patterns that we've seen in other literature, delayed posterior responses, very fast subcortical responses, etc. And in the resting state only data, it's really hard to see these phenomena. So we really like this protocol. It's easy. It gives us amplitude and lag in the units we want for a very low cost. And this study also highlighted what I would like to be a take-home message for this audience, but I'm sure that I am preaching to the choir here. We identified an individual with an incidental finding, eventually diagnosed as unilateral moya-moya. And you can see on the left here, without any consideration of lag, our CVR analysis would have identified a large area of negative vascular reactivity, which might be called steal. And you see a lot of this in the literature reporting steal, and it is a very real thing. However, in this case, when we think about lag, what we see is it's actually a very delayed response to the CO2 stimulus. And when we correct for that lag, we see that our CVR is quite typical in that region. It's healthy, it's just very delayed. And so without incorporating lag, we would have a very different clinical interpretation of this patient's physiology. So what is vascular steal and what is actually just a long delay? I think that it's difficult to say, looking back at the literature, if people haven't incorporated lag and dynamics into their analysis, what really are we looking at? But still, this absolute lag measure might differ with the CO2 characteristics. Did we have a block design, a sinusoid, a breathing task, or resting fluctuations? So we may not be able to compare just yet between these different experimental conditions. But if you'd like more information about this approach and our analysis, this lag GLM, I'll point you to this preprint, which is hopefully coming out soon in press as well. So there are pros and cons to adding breathing variations. Pro, it's very simple, it's inexpensive, and it's very safe. It's directed by the patient themselves. But on the flip side, that is a negative, right? We are depending on compliance of our patient. And I know in many clinical translational settings, that is something we don't want to have to rely on. So there's also variable execution from trial to trial, maybe with some of these breathing tasks. And there's going to be task correlated motion. So this may not be the solution for everybody, and I do think we should continue to push for methods that extract this information from resting state data. And maybe with my colleagues in this symposium, we can work together to try to get this quantitation and robustness from resting state data using some of what we've learned from this type of protocol. I also have people in my lab trying to improve the odds. So outside of the scanner, we can have people do our fMRI tasks, our motor tasks, and this type of breathing task, and track head motion, figure out what cues help people be more compliant with minimal motion artifacts. And so this is something ongoing, particularly as we're working into patient groups with maybe some type of impairment and younger pediatric participants. We're trying to make sure that we're asking our participants to do things in a way that really generates success when we move into the fMRI environment. Okay, so all of your physiology is also connected. So despite the fact we are trying to pin down CVR and CO2 changes, a lot is always going to be going on, and isolating these effects is an uphill battle. So for example, during a 3-back stimulus, we see that end-tidal CO2 is very much entrained by that. People's breathing fluctuates when they're thinking hard. And how would you know if that's happening unless you monitor end-tidal CO2? So if there's any take-home, it's this. Please record end-tidal CO2 in your data. It could give you lots of help along the way in terms of measuring and separating these effects. Furthermore, over time points, we see that CVR does seem to be related to other aspects of your physiology. So this data is in conjunction with my collaborators in Spain. They scanned 10 individuals 10 times over 10 weeks. And in each scan, they got a bunch of different things, but also a breath hold scan to measure CVR and all sorts of measures of their current state on that day, including things like blood pressure. And what they've observed is that this CVR parameter, day to day to day, does seem to vary with your blood pressure and your mean arterial pressure and your pulse pressure, the difference between systolic and diastolic. And you can see where in the brain that seems to be a main effect. Furthermore, we see, as reported in the literature, that women have lower CVR than men. But I'll highlight this relationship with blood pressure. Blood pressure fluctuates day to day, and we see that in our CVR amplitudes. And that is because we have these semi-quantitative CVR amplitudes to play with. So another motivation, perhaps, for getting that information. There's crosstalk between heart rate and end-tidal CO2. My student here is trying to get CVR in the spinal cord, which is very brave. And here's some traces that she's shown me where CO2 in blue looks very correlated or anti-correlated with changes in heart rate. So without incorporating CO2 into our modeling in resting state data, maybe these relationships really make it difficult to tease apart different physiological parameters and maybe different physiological lags. There's also some crosstalk between these factors and the brain. My colleague Ian Driver at Cardiff gave graded CO2 levels during MEG scanning where we're not meant to be dealing with anything vascular, we're meant to be focusing on neural signals. And indeed, he saw across all of our alpha, beta, and gamma bands, we see these changes, these reductions in activity associated with this graded hypercapnia stimulus. And indeed, he saw relationships even in resting fluctuations of CO2 with our MEG signals. So there's something happening with CO2 and neural activations. And then finally, I'll just wrap by saying that these systems are inherently coupled and they influence each other. So back in Cardiff, I demonstrated that we saw maybe splitting of functional brain networks when we were doing a CVR experiment, and where one network tended to show the CO2 changes and one network tended to show maybe the neural activation responses we expected from a task. And so we set to probe this a bit more explicitly in this study design, where we had a working memory task, a visual task, as well as this hypercapnia task to really get at CVR. Now, this is far away from what you might do in resting state analysis, but I think it's an interesting construct. So first, what we did is we averaged all of our data and we decomposed it using ICA, and we identified the default mode network, a task positive network, and a visual network associated with the time series of the stimuli I just showed you. So which network looked like our working memory task in a positive way and in a negative way, and which network looked like our visual task in a positive way. And we pulled out these three networks. Then I looked for what other networks existed that had spatial similarities to those networks using a dice correlation, overlap measure. And then finally, we looked at the time series of those networks, and they strongly reflected the hypercapnia stimulus. So we have pairs of networks that are spatially similar, but differentiated with ICA. And one of the network pair looks like our neural stimulus, and one is looking like our vascular stimulus. And what this means, I think, is still very much open to interpretation. There might be this network-specific regulation of our cerebrovasculature. perhaps our vascular system has developed to track a lot of our neural processes through childhood and maybe even through evolution. And that could be a very efficient way of supplying and regulating blood flow to specific networks of brain regions that function together. And it may also mean that cerebrovascular function could modulate aspects of neural networks. There's an interesting concept of the Hemo neural hypothesis, which I'll leave you to look up. It's a very fun read. And maybe vascular parameters split our networks. We've seen a lot of network splitting in the literature as well. And this idea of a vascular neural network where we consider all of these systems intertwined might be a little bit more productive than really trying to always tease these things apart, particularly when we go into pathology where aspects of the coordination is what's impaired. So I'll conclude some take-home themes. CVR amplitude and CVR lag give robust, exciting insight into cerebrovascular function. And I personally think it's helpful to amplify vascular signals to improve our modeling of these CVR parameters in our data. But a lot of physiological effects are interconnected. It takes a lot of hard work to really make measures that are specific and at least semi-quantitative for tracking over time or comparing between groups. So if anything, please measure end-tidal CO2 and try to use it in your analysis to get at that specificity. And isolating all of these different phenomena may not really be the most productive approach. Maybe we want to be even more clever and really try to study the coupling of all of the things that we might be talking about in this symposium. So with that, thank you for your attention to this talk. I'm excited to discuss more with you during the symposium discussion periods. I think this is an extremely exciting field, and I can't wait to see what everyone else is doing and pushing ahead in this domain. So thank you.
Whoops, I've disappeared into my background. Wait a second.
You can also start.
That's all right.
Okay. Well, thank you, Mala. That was a great talk. I will take my moderator's prerogative and ask the first question. So in your breath hold challenge, where you do the multiple breath holds at the beginning in order to sort of calibrate your experiment, is there any reason you couldn't do those breath holds at the end of the resting state period? My concern would be that you might get some sort of hangover effect from doing them at the beginning.
Yeah, we've been thinking about that a little bit more as we go. I think putting them at the beginning was purely a practical thing. People are paying attention in the beginning of a scan, so we could count on it. It was a bit easier. But yes, the long-term consequences of these modulations on anything subtle happening in terms of intrinsic brain behavior, I think that is a very interesting question. And yeah, maybe it would buy us something down the road in the next subsequent 10 minutes. I don't know. When we do some really basic assessments of the characteristics of that kind of resting state fMRI portion after breathing modulations, we don't see anything jump out at us, but that doesn't mean there isn't something in there. So yes, I think you could put it at the end.
Okay. Jean, you had your hand raised? Or?
Yeah, I did. I have two questions for you. First of all, very, very nice talk as always. I always enjoy your presentations. So my first question is about the similarities between CO2 and heart rate and spinal cord. That's I've never seen that in the brain. So just maybe some elaborations on that. And the second question is about what people should do if they don't have CO2 traces with their breath hold.
Yeah, so the data I showed were just from phys traces. They didn't have the actual spinal cord nightmare. So I wasn't showing any data from the cord. That was just traces in different stages of developing sort of nuisance regressors trying to clean things up. So probably similar to what you're seeing in the brain. It's all kind of the same stuff. How they manifest in the cord, we're still figuring out, and looking at latencies would be ideal, but we're not there yet. And then the next question was, sorry?
So for those that don't have a capnometer, and there's also data out there that was done using the breath hold challenge, but without the CO2.
Yeah, I think so. Joanna, I think she's in the meeting, and I think she's outlined lots of ways of analyzing breathing tasks in that review I highlighted. You certainly can do it. And the scaling, maybe it's not critical for your question, right? So you can certainly still try to fit that variance and look at probably latency quite robustly, even though you may not know exactly what type of CO2 change you're getting. I think harking back to a conversation earlier today, measuring end tidals through a nasal cannula is imperfect as well. It has utility, but it's also imperfect. So I do believe you make the best of what you got. And so I think, Jean, have you, and I was asking Katie about this as well, end titles are not always consistent with some participants. When people breathe very quickly, you don't get a nice end tidal value, et cetera. So trying to estimate that using other data that you do have and the deep learning, the neural networks that have been thrown at this problem to try to fill in the gaps in the data acquisition. I think that is probably a very useful thing to bring in at some point.
Thanks.
I had a question from Ben, and that was, would you be able to analyze the CVR data if instead of just end tidal CO2, if you also had end tidal oxygen, could you do something equivalent to the breath-to-breath exchange ratio that Phoebe Chen presented?
Yeah, I mean, we have oxygen. We typically are always collecting 2 for the price of 1 with the gas sampling that we have. Most systems are dual purpose. We have not actually brought in oxygen to our analysis. I think as I raised in some discussion, when there's collinearity, putting everything into a model, it's a bit ambiguous and it is confusing. So, but yes, these signals are very collinear, and so potentially incorporating it in some more clever way than just sticking both in the model, but actually combining them first, it could be productive, but I haven't done it.
We have a question from the Q&A. Your end tidal CO2 measurements during the 3-back task appeared to follow the input function of the paradigm. If you were to use the end tidal CO2 data as a regressor, you probably would not detect any activation, and yet this would not mean that there were no changes in the neural activity. How would you handle the end tidal CO2 data in that case?
I'd go home. Like, what are you going to do, right? If you have things that are completely time locked to each other, separating them out is really hard. I mean, if you have amazing resolution and excellent patience and advanced analysis methods, maybe the idea of latency could be brought in. There are slightly different characteristics to bold T2 star changes associated with these 2 sources of fluctuations, but I think it is quite difficult to tease them apart. So, this block design was flawed in terms of looking at what I wanted to see.
I think the lesson we've learned from today's sessions is that if you're not doing respiratory and cardiac pacing simultaneously, you're really, sort of wasting your time. I'm kidding. Okay, let's see. Do we have any other questions?
So I actually want to ask Molly. So it is a nice talk. So it is pretty good to incorporate the breath hold, couple of breath hold before the resting state, because yeah, we find a similar thing is that in the resting state, the correlation is with the gas metrics is pretty poor. Sometimes, yeah. Yeah, and
yeah, if you're a professional MRI volunteer and you breathe like an absolute rock throughout the experiment, there's no variability to latch onto with this type of analysis. So, I mean, we did breath holds, we tried deep breaths, but I think the main thing is to have some sort of robust variation that just gives you the sensitivity that you need. But I'm pretty agnostic as to what that has to look like.
But I agree that, say, incorporating the breath hold, the after effect of the breath hold, so it can help to, say, give the challenge to the subject, so that, because usually for the resting state, we usually consider the cerebral hemodynamics, it can auto-regulate. It can be autoregulated within the body. So if somebody, they cannot auto-regulate it in the resting state, obviously they are pretty sick, right? So giving some charge actually helps, say, especially in the patient population, to say outline any abnormalities.
Yes, I would also though flag my own ignorance in that when we see some sort of reduced amplitude of CVR or increased amplitude of CVR, I don't think we always know exactly how to interpret that because so much is going to depend on the person, their baseline physiology and lots of things that I don't have access to with this particular type of data set. So I think there are some interesting studies with all of fMRI activation. Is a bigger activation better or worse? And I think sometimes with CVR, we run into this question mark as well. Some pathologies, it's clear reduced CVR is bad, but there may be cases where actually something about the physiology of that brain with whatever's happening there means that amplitude effect is a little bit more complex to interpret. But yes, I in my lab, we like to give these types of challenges. It gives us more information is always more interesting.
I'll just mention parenthetically that approaches like this are being used to uncover defects in the response functions that map onto where glioblastoma has migrated to, but not yet manifested in, for example, contrast MR. So there are a lot of medical applications for these things as well.
Yeah, I was interested. I mean, I really like the idea of I forget what you call it, the hemo something hypothesis, where you've got these neuronal, coupling of the vascular networks that reflect the neuronal networks that they're talking to. I was wondering if seeing, you see that they're very similar between the tasks that you looked at. Would there be cases where differences between those two networks would show some sort of, perhaps a pathological condition that might be bad? I mean, you could certainly see why you would want your circulation to be synchronous within a network that's working together. I mean, it seems it would have an advantage.
Yeah, and I think they are different. There's just an interesting amount of overlap between very distal regions in terms of vascular characteristics and regulation and neural activation, co-activation patterns. So there's overlap, but they are not the same network. There's at least half of the network was different, and that's how they were able to be kind of disentangled with the analysis I did, which has room for improvement. So I think, if we take a cue from some of the functional connectivity analyses where network splitting is becoming quite an interesting topic, and very personalized maps of nuanced network node boundaries and edge, like where we're starting to see differences in that level of structural specificity that does map on link to behavioral and functional outcomes or other measures. I think that would suggest that understanding nuances of exactly where vascular regulation and neural co-activation patterns, where those boundaries and overlaps really lie, could be another productive avenue.
Please, I think we're running out of time. We can save the rest of the questions for later.
Yeah. I mean, we did have a speaker drop out, so we will have time at the end to continue this discussion. Okay, so I guess we're going to move on to our second speaker. And as soon as I can find, here we go. Yes, well, our second speaker is Dr. Ahmed Khalil. Dr. Ahmed Khalil studied medicine in Sudan and did his postgraduate studies in internal medicine, neuroscience, and neuropsychopharmacology in the UK, France, and Germany. During his PhD, he worked on developing and validating advanced MRI methods such as perfusion, diffusion, blood-brain barrier, and oxygenation imaging in cerebrovascular disorders. He is currently a radiology resident and postdoc at the Charité University Hospital in Berlin, Germany. And just as a personal note, having been on our weekly sessions, it's always interesting to hear what Ahmed has been up to in the previous week. He often has to take time off from research to save people's lives, which is always interesting to hear about.
Hello, everyone. My name is Ahmed Khalil, and in this talk, I'll be giving an overview of the role of hemodynamic lags in cerebrovascular disorders, both from a research and a clinical perspective. So we'll be covering two major aspects related to hemodynamic lags. The first is the use of information on lags to infer something about brain perfusion and the dynamics of blood flow in the brain. The second aspect relates to how these lags influence and sometimes interfere with the assessment of the brain's functional organization, which is a particularly important issue in patients with cerebrovascular diseases. So we'll be starting off with the blood flow side of things. The assessment of blood flow in cerebrovascular disorders is very important. In acute stroke, for example, the status of the brain's blood flow is directly relevant to how patients are treated. So in acute stroke, we often distinguish between areas of the brain that are very severely damaged to the point where the tissue in that area is either irreversibly or very close to irreversibly damaged. We call that the infarct core. And this is shown in this schematic in blue, and it can be approximated using diffusion-weighted imaging or diffusion-weighted MR imaging. That's this area of high signal or hyperintensity that you see in these two example patients. Now, often what we see surrounding the core is an area of tissue where blood flow is extremely low, but the tissue is still viable, at least for the time being. This tissue is threatened in the sense that the damage occurring to it might turn irreversible if no treatment is administered. This area shown in red here in the schematic is known as the ischemic penumbra and can be approximated using perfusion imaging. So what we see on the slide are two different patients. The patient on the bottom has little to no penumbra and is therefore unlikely to benefit from acute stroke treatment. The patient on top has a relatively large penumbra and a relatively small core. And these patients tend to have the most to gain from acute stroke treatment. And so what we want to see after treatment is a regression of the penumbra, leaving behind only the irreversibly damaged core. In other types of cerebrovascular disorders, like chronic steno-occlusive disease of the large arteries, we know that bulk blood flow to the brain interacts with a number of different other factors to determine what the patient's risk of developing a stroke is. There are many of these factors, like the status of the microcirculation, the availability of alternate routes of blood flow, the composition and structure of the arterial plaque that's actually narrowing the arteries, and so on. And the first paper to come out looking at the use of hemodynamic lags for assessing perfusion in cerebrovascular diseases was by Liv et al. In 2013. They scanned a group of stroke patients using a standard stroke MRI protocol and added dynamic susceptibility contrast MRI and resting state functional MRI to that protocol. And they found that areas of hemodynamic lag, which I will also refer to in this talk as bold delay, correspond spatially quite well to areas of disturbed tissue perfusion measured using DSC MRI, or dynamic susceptibility contrast MRI. This is shown on this slide for 6 different patients. And on top, we see the infarcts on diffusion-weighted imaging. And the bottom 2 rows represent the perfusion lesions or the perfusion deficits measured using bold delay and DSC MRI. And as you can see, they correspond kind of visually, spatially quite well to each other. Since that paper, more than a dozen other studies have come out looking at essentially the same thing. And most of these studies have compared hemodynamic lags with more established perfusion imaging methods like DSC MRI, arterial spin labeling, and single photon emission computed tomography. Importantly, the very early studies that we just mentioned were followed by a number of different papers that tried to quantify the relationship between lags and measures of perfusion derived from more established techniques. So in 2015, Kristen et al. Studied a group of Moyamoya disease patients and found that the correlation between bold delay and the time to maximum perfusion parameter, also known as Tmax, which is derived from DSC MRI in different regions of interest, was quite high. The correlation was quite good. They were also the first to show that there are differences in how well bold delay correlates with Tmax, depending on which reference you use for the lag analysis. In their case, correlations were higher when a sagittal sinus reference was used compared to a whole brain reference. Soon after that, Siegel et al. Published a study where they looked at lags in more than 100 patients, starting about 2 weeks after the onset of acute stroke. They found that increasing lag is associated with reduced blood flow as measured using arterial spin labeling. And then in 2017, we published a paper comparing lags with a number of different perfusion parameters derived from DSC MRI in a group of acute stroke patients scanned within about a day of symptom onset. Here we found that lags correlate most strongly with Tmax. This indicates that we're measuring, or what we're measuring with lags in stroke patients is likely a bulk delay in the arrival of blood flow to certain brain regions. And people haven't just looked at lags in acute stroke, but also in other cerebrovascular disorders. So the paper I mentioned earlier early on by Kristen et al. Looked at patients with Moyamoya disease, again, showing really similar maps derived from lag analysis and DSC MRI across patients. And then another study by Amami et al. Included both stroke patients and patients with chronic steno-occlusive vessel disease, and again compared lag maps with DSC MRI. And like Liv et al., they found a very good spatial correspondence between lesions derived from both techniques. Wu et al. Studied a group of patients with chronic steno-occlusive disease as well, using both DSC MRI and lag analysis. And the lag analysis was done using 2 different reference signals, the global mean and the superior sagittal sinus signal. And again, both techniques showed very similar results in the study. You can see here's a representative patient's Tmax map and the same patient's lag maps derived from the 2 references. In addition to that, the authors also showed that after administering the cerebral vasodilator acetazolamide, the similarity between lag maps and Tmax was substantially reduced. This indicates that at least part of the signal driving the lags might be related to vessel caliber. A few years ago, we asked ourselves the question of whether lag analysis is capable of detecting changes in perfusion over time. And we were particularly interested in looking at the kinds of changes that are relevant to stroke treatment. So we looked at this in a group of stroke patients scanned within a day of stroke symptom onset, and then again 24 hours later. So on the left side of the screen, you see an MR angiogram of one of these patients. And this shows an occlusion of the distal part of the left posterior cerebral artery marked by this arrow here. You can see there's flow in the proximal posterior cerebral artery and it suddenly stops. That's where the artery is blocked. And if we look at the histogram of the lag values and the Tmax values in the vascular territory supplied by that artery, we see some delayed voxels in both techniques here and there. Now, this patient received treatment, and 24 hours later, we see their follow-up MR angiogram. We see that the previously blocked vessel is now patent, it's now opened, it's now unblocked. And this kind of recanalization of the vessel was accompanied by a normalization of the delayed voxels on both bold delay and Tmax maps. This is shown again here visually on the actual perfusion map. So at baseline before treatment, you see these areas of hemodynamic lag and prolonged Tmax in the territory of the left posterior cerebral artery. And these areas of delay then resolve and reverse the next day after treatment. And importantly, this reversal is not seen in cases like this patient, where the occluded vessel, here in this case, the right middle cerebral artery, shown again by this small red arrow here, is still occluded 24 hours later. And this results in a persistence of these lags within the corresponding vascular territory on follow-up imaging. And this persistence can also be seen here or appreciated here, of course, on the Tmax maps. So lag analysis seems really promising in the setting of acute stroke as a diagnostic tool. But the thing with acute stroke is time is a very, very critical factor, and delays at every step in patient management have to be kept to an absolute minimum. So in this next study, we looked at whether we could shorten the standard resting state fMRI scan that we use for lag assessment. So what we did is we took the standard full scan of about 5.5 minutes, and we progressively shortened it to end up with scans of 5 different lengths. And then we looked at how the lag maps derived from these scans differ. So we found that in terms of the volumes of the areas of reduced blood flow on the lag maps, there wasn't actually much difference between the scan lengths. But in terms of the amount of noise on the lag maps, as assessed by experienced raters, it was this noise was only significantly higher in the 2 shortest scan lengths. This was the same was true for the ability of the raters to actually interpret the maps. It was only kind of reduced in the interpretability of the maps was only reduced in these 2 shortest scan lengths. And these are some examples of the patients in the study sample. You see the maps derived from the 3 longest scans all look quite similar, but the noise and the contrast between areas of normal blood flow and abnormal blood flow on the maps is substantially reduced here in the shortest 2 scans. So this study shows that we can save about 2 minutes of scan time without sacrificing too much in terms of the quality and interpretability of the bold delay maps, which may not sound like much, but 2 minutes means really a lot when you're scanning acutely ill patients. So what we've been doing in Berlin over the past couple of years is trying to integrate lag analysis into the workup of acute stroke patients. And the way that this works is that the patient is brought to the hospital with suspected stroke. And if there are no contraindications to MRI or indications for them to go directly to have an emergent CT, they get an MRI that includes a 3 to 5 minute resting state fMRI scan, depending on the specific clinical situation of the patient. Then with a few mouse clicks, the resident working at the scanner can send the acquired images to a dedicated server that running a software package from the University of Freiburg called NORA. And within a couple of minutes, the data is processed and the lag maps are visualized along with a few quality control metrics to the resident so that a decision regarding therapy can then be made. Now, this kind of integration into clinical routine can really come in handy, as illustrated in this case. This is a young patient in his mid-20s who presented with sudden onset unsteadiness and trouble moving his tongue that started about 15 minutes before he came to the hospital. He got an MRI, and as you can see, the diffusion-weighted image was completely normal. The MR angiogram showed an occlusion of the left superior cerebellar artery, shown here by this red circle. You can see the right superior cerebellar artery is patent, is open. You can see flow going all the way distally, but here it starts off with a little bit of flow and then abruptly stops, and then there's no distal flow, and that's a blocked artery. And then the lag map or the bold delay map showed a large area of delayed blood flow in the left cerebellar hemisphere. And therefore, this patient was diagnosed with acute stroke and total perfusion-diffusion mismatch, which basically means that there's some severely hypoperfused tissue, but no severely or irreversibly damaged tissue. And he received intravenous thrombolysis based on this MRI. Now, on the next day, we did some follow-up imaging, and we see a very small area of diffusion restriction here in the left cerebellar hemisphere. The left superior cerebellar artery is now patent, so it looks kind of, you can see flow kind of distally here, and also in the more distal branches of this, or in the more distal segments of this artery. So it's been essentially the blockage has been resolved. And with that resolution of this blockage, there's also resolution of the area of delayed perfusion in the left cerebellar hemisphere, at least a partial resolution. So this case highlights the importance of perfusion imaging in stroke in general. That vessel occlusion that we saw just a moment ago is relatively easy to miss. It can also be mistaken for some kind of artifact. And so perfusion imaging gives us that extra bit of information that helps us reach the correct diagnosis. The case also highlights how treatment response can be monitored using perfusion imaging. And here, of course, with the added advantage of not having to give the patient contrast agent multiple times, as is the case if we had used, as is the case, for example, with DSC MRI. So far we've been talking about detecting lags and changes in perfusion using cross-correlation. And it turns out that there's other ways to do this as well. The basis for these kinds of other methods is that we know that disturbed perfusion is reflected in the bold signal in multiple ways. There's lag, which is what we've been talking about so far, but there's also changes in oscillation frequency and signal amplitude associated with disturbed perfusion, and we've known this for quite a while now. So in this next paper, we took advantage of this kind of collection of signal changes associated with disturbed perfusion and applied a signal decomposition method, spatial independent component analysis on fMRI data from a group of acute stroke patients. And as it turns out, when you do that, you get all the usual components like resting state networks and components reflecting head motion and physiological signals. But what you also get is something very interesting that's shown on this slide here. So we're looking at 3 different patients here. We can see their infarcts on the diffusion weighted imaging here, here, and here. And then the areas of disturbed perfusion on these Tmax maps that correspond to these infarcts, basically. And then what we also see is 1 component per patient that kind of spatially, again, looks very, very much like these Tmax lesions. So it's very asymmetrical. It's very kind of, it has a structure that looks like something vascular, essentially, and you can confirm this by kind of comparing it to these Tmax maps. And the really useful thing about doing it this way is that you can pick up these components that reflect disturbed perfusion, which we call HICS, or hypoperfusion independent components, even in cases where the patient moves so much during the scan, like in this patient here, that cross-correlation based methods of lag analysis completely fail. They're completely kind of, these maps, this map here, for example, is completely kind of uninterpretable. But we see in this case, for example, this is the patient's infarct here on the diffusion weighted image in the right middle cerebral artery territory. The time drift analysis map here is completely uninterpretable. But the spatial independent component analysis yields a component that looks very much like the perfusion lesion on Tmax. We then went on to show that these hyperperfusion independent components have a completely different signal signature compared to other components. So their oscillations are delayed compared to the venous, sinus, and global signals. They're mostly restricted to a single vascular territory, and they generally have kind of a signal, their signal is mostly kind of in lower frequencies than components reflecting resting state networks. And we then use this signature to train an algorithm to automatically pick out and identify these hyperperfusion independent components with fairly high accuracy. So what we have here is a way to identify pathological perfusion using fMRI data that is robust to patient motion, doesn't require the user to choose a reference, and it can essentially be automated. So now we'll move on to how hemodynamic lags interact with the assessment of the brain's functional organization. We know that the state of the brain's functional organization, assessed, for example, using functional connectivity metrics, provides useful information in cerebrovascular disorders. So the following are just a few examples of this. In this paper by Siegel et al., the authors found that impairments in certain domains, such as visual and verbal memory following stroke, were much better predicted by changes in functional connectivity than by the location of the lesion, the location of the stroke itself. Then there's other studies like this one by Puig et al. That showed that the pattern of functional connectivity a few days after stroke onset can actually predict clinical stroke outcome 3 months later. Patients with better clinical outcomes at that 3-month time point basically had higher baseline functional connectivity between brain regions than those who had worse clinical outcomes. And so we and others have suggested that these changes in the brain's functional organization might in the future help us provide more effective rehabilitation and therapy for stroke patients by essentially identifying subgroups that are likely to respond to certain therapeutic strategies like non-invasive brain stimulation. And this would hopefully reduce the large variability in treatment response that's often seen with such therapies. So as we've heard over the course of the symposium, the systemic low-frequency oscillations that drive hemodynamic lags overlap with the oscillations that we use to assess functional connectivity. And this unfortunately means that any disturbances in these systemic low-frequency oscillations, for example, as a result of abnormal perfusion, can also appear as a disturbance in functional connectivity. This was first shown by Kristen et al., who described how seed-based functional connectivity that seems abnormal in patients with Moyamoya disease and other forms of chronic cerebral hyperperfusion normalizes after one corrects for lag by realigning the time series to the reference. So note here, for example, in the default mode networks of both these patients, before lag correction, the default mode network looks quite asymmetrical. And the missing parts of these networks are actually overlapping with the areas of delayed blood flow. But once you correct for hemodynamic lags, you recover these kind of previously lost regions or parts of the network shown here in blue. And then from the same research group, Jahanian et al. Went on to suggest other ways to correct for the effective pathological lags on functional connectivity. They described a multi-delay procedure where they basically perform seed-based analysis of functional connectivity using several different time-shifted versions of the bold signal time course within the seed, and then concatenating all of them together. More evidence for the effect of delayed systemic low-frequency oscillations on functional connectivity analysis comes from Siegel et al.'s paper from 2016, which again looked at more than 100 patients scanned a few weeks after stroke onset. They showed that seed-based functional connectivity after lag correction in stroke resembles connectivity seen in controls more than kind of before lag correction. They also made a couple of very important observations. Firstly, that the functional connectivity maps from these stroke patients after lag correction are not identical to those of controls. Secondly, the correlations between changes in functional connectivity and behavioral measures are reduced after lag correction, but they don't disappear completely. And this suggests that stroke is associated with changes in functional connectivity even after accounting for disturbances in blood flow. But at the same time, the study emphasizes that the interaction between disturbed blood flow and disturbed functional connectivity should not be ignored. Wu et al. Performed a similar lag correction procedure by basically shifting the time courses of all voxels by the amount of lag relative to the reference signal, and then rerunning the functional connectivity analysis. And by doing so, they were able to recover parts of the resting state networks, like the default mode network and the sensor-motor network in a group of patients with chronic cerebrovascular diseases. So we've established that lags are a metric for assessing cerebral perfusion and cerebrovascular disorders that is non-invasive, it's accurate compared to more established methods, can be performed quite quickly, and is sensitive to therapeutically relevant longitudinal changes in perfusion. We've also seen how lags can be a potential confounder when it comes to assessing functional connectivity in cerebrovascular disorders. And we know that correcting for this lag is possible, but as we've heard also in other talks, it's not yet clear what the best way to do this is. And so whenever we're looking at functional connectivity in a patient population like this, we have to acknowledge and think about the complex interplay between hemodynamics and connectivity, particularly how this relationship becomes even more complex in disease states. That being said, we should also keep in mind that there are other uses or other types of useful information that can be derived from functional MRI and cerebrovascular disorders. We're currently, for example, exploring what the bold signal tells us about the status of the large vessels in stroke, as well as the integrity and viability of severely underperfused tissue. And of course, there's the use of the bold signal to assess hemodynamic reserve and vascular reactivity that we heard about from Molly Bright, which also provides really useful information in patients with cerebrovascular disorders. So this is just a list of references for the studies that I mentioned during this talk. And finally, I'd like to thank all these wonderful people who I work with on these on things that I mentioned or presented today, as well as the different sources of funding for my research. And I'd like to thank you all for listening and also for attending this this symposium.
Thank you very much, Ahmed. That was a great talk. Have a number of questions from the Q&A session. People are putting the questions where they're supposed to now. First one is, what is the minimum sampling requirement for bold delay mapping in 3T MRI? And is it applicable to all sorts of populations?
So sampling in terms of the sampling rate or the sampling, like the time, like the total duration of the scan? Not sure.
Wasn't clear to me, so why not answer both?
Yeah, I think, yeah.
So
I think, so the paper that I mentioned during my talk, the one about kind of trying to sort of shorten the scans, that was of course done in acute stroke patients. And the thing we have to all keep in mind when we think about acute stroke patients is they have very severely underperfused tissue, right? So we're looking at very large changes there. So that's probably why you can kind of go down to these very short scans and still be able to pick up these large changes. It's unclear kind of in other patient populations that have more subtle changes in perfusion. You know, people have started to look at lags in Alzheimer's disease, patients with Alzheimer's disease, for example, where we know there are changes in perfusion and in blood flow, but generally speaking, they tend to be less severe than, of course, patients with cerebrovascular disorder, primary cerebrovascular disorders. And so in those kind of populations, as far as I know, nobody's really looked at this, like how much data you need, how long the scan has to be in order for you to be able to reliably pick up on these lags. But I think that's probably one of the things that needs to be looked at kind of on a patient population specific basis. And as for the sampling rate, kind of, I mean, we moved to multiband resting state a few years ago for the lag analysis. So we actually have like a repetition time of 0.4 seconds, so quite fast. That's also what this paper, or most of these paper studies that I mentioned were based on. But it's not yet, I think, completely clear what that kind of like what a higher TR I think gets you in terms of advantages for lag analysis. I mean, one thing that I often just kind of think of, like one of the justifications that I think of for having such a high sampling rate is probably then it's easier if you want to kind of filter out respiratory and cardiac signals. You're probably better off kind of at a higher sampling rate, but it's also not completely clear that improves the lag analysis.
Okay, I'm going to go with two of the questions from the Q&A, and then I'm going to get to the panelists. Highly interesting talk. Thank you. One question regarding the association of bold lag and other perfusion measurements. What could be an interpretation of the, judging by the figure, strong negative correlation between bold lag and CBF? Compensatory increase in microvascular blood flow if macrovasculature is impaired? Question.
Yeah, that's I think that's one possible explanation. I mean, that figure from the paper by Siegel, that was CBF measured using ASL, using arterial spin labeling. We haven't found such a strong relationship between lag and CBF derived from DSC MRI. Of course, there are differences between CBF derived from DSC MRI and ASL. So I'm not sure we really know, like, and as far as I know, like, I'm not sure if this finding of this strong association between lags and CBF derived from ASL has been kind of reproduced or been shown further. But that could be one possible explanation. It could be that essentially, yeah, you have kind of a macrovascular effect, right? So a delay in bulk blood flow kind of reflected in reflected in these lags kind of reflecting this delay in bulk blood flow, but that certain regions, of course, are then simultaneously then affected by kind of reduced microvascular perfusion on a very kind of small level that is reflected as a reduction in CBF. But I think, you know, it's likely that even if that is the case, the bulk blood flow impairment part is probably still the larger driver of lags, I think, or that's at least what the data we have in stroke. Again, all this is in stroke because yeah, that's where it's been kind of best studied.
And then finally, from a clinical standpoint, do you think that the post-treatment fMRI can delineate between tissues containing regaining perfusion and the potential of tissue damage from reperfusion injury? In other words, in the post-treatment scans, were the residual hotspots of bulb delay due to impaired perfusion that is still present, or the bulb delay from a potential tissue damage due to reperfusion injury?
Yeah, that's an excellent question. That's something that I also kind of wondered about a lot, especially with this one case report that I showed you from this young patient, because you do see then in the area, so on follow-up imaging, I didn't show the Tmax maps, but actually the Tmax maps completely normalize. So the tissue just reperfuses, and this delayed bulk blood flow measured using Tmax just completely normalizes. While in the bulb delay map or the lag map, you see an area of kind of persistent delay. It's much smaller than the initial area, but it's still there, and it's within the infarct core. It's within the diffusion lesion, and I don't really know what that means. I mean, it could be many things, like that area of tissue, like that part of the tissue is severely damaged, right? So there you can think of, like, I don't know, a dozen different pathophysiological processes that might be driving this lag or this apparent lag in that area on follow-up imaging. And one of them could very well be reperfusion injury or a consequence of reperfusion injury.
Okay. Tom?
Thanks. Yeah, great talk. So I had a question. So, you know, with the standard ASL, like pulsed ASL or, you know, continuous ASL, there's a lag built in because of the methodology, but there's this velocity selective ASL that doesn't have this, you know, transit insensitive, and you can measure blood flow even in areas with very long collateral flows, you know, such as in moya disease or stroke. So do you have a sense of, if you had, you know, have you tried that approach? And if you have tried it, how would you, you know, is there still, you know, what would be the best way to combine, you know, sort of a more accurate CBF measurement with these lag measurements? Is there, you know, do they, you know, can you sort of speculate on how they might help each other in terms of, you know, let's say you had a CBF measurement that didn't have any lag issues with it, you know, would the lag information still be useful for you to make your clinical decisions?
Yeah, I mean, the thing is, of course, if you're talking about MRI and acute stroke, in terms of kind of the delineation of the penumbra, generally speaking, it's considered that kind of lag-based measures or measures of bulk blood flow delay are actually more useful than measures of microvascular perfusion. This is a little bit different, more useful in delineating the penumbra. They're not perfect. So Tmax, for example, is kind of the gold standard, or at least using a threshold of Tmax. It's not perfect, but it's, I think what's been shown kind of time and time again is that it's probably better than CBF, or something like CBF, at least derived from DSC MRI. So the lag information, this information about bulk, kind of delayed bulk blood flow or macrovascular blood flow, is actually really, really useful. So in acute stroke, but but one thing that would be interesting to do, for example, in terms of a comparison with ASL, if one had something like velocity selective ASL, would just to kind of look whether that relationship between CBF and lag still kind of holds. So when you kind of take out maybe the lag or the bulk, delay the transit time information, do you still get that relationship, or does it completely break down? And then does lag kind of not reflect any part of microvascular perfusion? Kind of, it would be unlikely, of course, but it would be interesting to look into that. We haven't done that yet. I'm actually I'm looking for a velocity selective ASL sequence that is kind of fast and reliable enough that we can actually use it in our stroke patients. We have a huge issue with like time. So, you know, a 10-minute sequence usually doesn't work on like 90% of our patients or something. So again, sounds very, very kind of, you know, 10 minutes, what's 10 minutes? But most of our patients are really severely affected, and they simply can't stay and like they can't stay in the scanner for 10 more minutes. So.
Great, thank you.
Jonathan, you had a question?
Sure, thanks for that talk. We've been looking at this with our plumbing hats on a lot, but 10 years ago, as resting state was getting popular, the neural hats were much more on than the plumbing hats. And in stroke, it was especially exciting to think that maybe we would be able to detect effects that were due to diaskesis or would reflect reorganization as people regained capabilities. The data you're showing are overwhelmingly of the penumbra and recovery of more normative lag function as time goes on. Just like in an anecdotal sense, what is your level of hope of detecting the more diaskesis and reorganization related effects that were initially very exciting within this particular clinical problem?
Yeah, I mean, I still have a lot of hope. I think, for example, that there's just simply not enough being done on that, on like looking at how, like what happens to functional connectivity and functional organization when you at least try to kind of extract, like remove the hemodynamic information. I know, of course, this is kind of what this whole symposium is about. It's complicated, it's not that easy, but at least like, you know, we've learned like over the course of the symposium, we can kind of try to do it. There's denoising ways that can kind of regress out these lags and stuff like this. And very few studies have actually done that. So one study was the one by Siegel et al. And that's the one that kind of gives me the most hope, to be honest, because they did try to kind of regress out the lags, and you still see a relationship between functional connectivity changes and behavioral measures in stroke, and a fairly strong relationship. So, so I definitely kind of have a lot of hope. I just think we just need to be doing a lot more to try to understand what the best way is to kind of get rid of these, or kind of remove these signals in order for us to get a cleaner view of the functional organization. Yeah, but that's not being done yet. Oh, sorry, Blazer.
We need to move on.
Yeah.
And hopefully we can get back to this a little later. So I'm going to introduce our next speaker, Ioannis Pappas.
I'm going to do this in a sort of meta way. I'm going to present my own video, but also not talk. So let's see how that goes.
Okay, so while he's setting that up, Dr. Ioannis Pappas is a postdoctoral fellow at UC Berkeley and soon to be faculty at USC's Keck School of Medicine. After training in engineering and computer science, Ioannis obtained his PhD in clinical neuroscience from the University of Cambridge, looking at neural correlates of anesthesia and brain injury. His toolbox includes task and resting state fold fMRI, perfusion-weighted imaging, diffusion-weighted imaging, as well as computational behavioral modeling. His main focus as a postdoctoral fellow has been brain reorganization and plasticity after injuries such as stroke. In particular, his research is focused on pharmacological interventions that can augment cognition, behavior, and neural function in healthy and diseased individuals, and how these inform targeted rehabilitation strategies during recovery from injury.
Thank you. Hi there. I hope you're enjoying the conference so far. My name is Ioannis Pappas, and I'm a postdoctoral fellow at UC Berkeley. In this talk, I will discuss hemodynamic lags and neuropharmacology. The neurotransmitter dopamine is well known to play an important role in complex cognitive functions, such as working memory and cognitive control. Early work found that depletion of dopamine in the non-human primate prefrontal cortex, or PFC, impairs the ability to do certain delay response tasks and increase susceptibility to distraction. In one of these works, Patricia Goldman-Rakis and colleagues examined the functional contribution of dopamine to the primate dorsolateral prefrontal cortex, or DLPFC, by infusing a neurotoxin agent into the DLPFC to enhance dopamine depletion. Thus, they created lesions with very large dopaminergic depletions restricted to the DLPFC. Performance was measured in a delay response task by quantifying the number of correctly remembered responses over different delay periods, producing graphs like the one shown on the right. What was found was that these lesions markedly impair performance in dopamine-depleted monkeys, as shown by the dark graph right here, compared to the monkeys right before the surgery, as shown by the white line graph here. And those effects were similar to those seen with DLPFC ablations. Thus, all in all, rodent and non-human primate research has demonstrated an important role for prefrontal cortex dopamine signaling in the stabilization of cognitive performance, as well as in the maintenance of more abstract representations such as attentional sets or task rules. When stratifying the components of dopamine signaling in the human brain, one can first focus on D1 receptors. D1 receptors are highly expressed in prefrontal cortex. At optimal levels of dopamine, the D1 receptor is thought to promote cognitive stability during tasks by enhancing the excitatory and MDA receptor currents that facilitate recurrent excitation in PFC pyramidal cells and reduce noise from neighboring cell populations representing competing or irrelevant task features. Although D1 selective agonists are not yet available for experimental use in healthy humans, to examine the impact of PFC dopamine levels on cognitive stability, researchers have capitalized on a common polymorphism in a gene encoding COMT. There are two types of COMT in the general population, the VAL variant and the MET variant. The latter is associated with a considerable decrease in enzymatic activity that results in accumulation of extracellular dopamine and is hypothesized to primarily bind on D1 receptors. Thus, one can think of METs as high prefrontal cortex dopamine subjects and VALs as low prefrontal cortex dopamine subjects. Another important component of dopamine signaling is the D2 receptor. D2 receptor expression in the human prefrontal cortex is considerably lower than that of the D1 receptor. The striatum, though, is richly enriched with D2 receptors. D2 signaling flows along connections between the striatum and the PFC. The striatum specifically receives topographically organized PFC inputs and propagates information along two parallel pathways through the basal ganglia circuitry, the putative direct and indirect pathways that ultimately excite or inhibit, respectively, thalamic projections back to the cortical regions of origin. The role of D2 in modulating cognitive control is less clear. In their dual-state neural attractor model, Darstevich and Siemens propose opposing actors of D1 and D2. Specifically, they argue that at moderate dopamine levels, the PFC enters a D1 dominant state characterized by stable representations, as I mentioned before, whereas when dopamine levels are low or high, the PFC transitions to a D2 dominant state in which shallow and unstable representations exist. As in PFC, there is also genetic polymorphism affecting aspects of DA signaling in the striatum, the ANKK1, TAQ1A. For example, the minor A1 plus allele of this polymorphism is associated with reduced D2 receptor density compared to the A1 minus homozygotes. Although researchers have emphasized the beneficial influences of PFC dopamine, data suggests a more complicated picture. Overall, studies have converged to an inverted U-shaped dependence of performance on putative PFC dopamine. Starting with previous work in non-human primates and rodents, researchers have suggested that the effect of D1 receptor activation on neuronal signal-to-noise ratio appears to follow an inverted U-shaped pattern, such that dopamine levels that are either too low or too high impair working memory and cognitive performance more generally. In humans, there is no direct evidence of baseline dopamine, but evidence comes, as I mentioned before, from polymorphisms in combination with pharmacological interventions. In general, the high dopamine met individuals often show lower levels of PFC activity and higher cognitive control and working memory performance than those low dopamine VAL individuals, as shown on the figure here. In addition, studies have shown that these VAL low dopamine individuals' performance under the influence of tocopone, which is a COMT inhibitor, is improved to more closely resemble than that of their MET peers, as shown by this transition arrow right here. Conversely, for the MET individuals, their performance worsened, as shown schematically by this arrow right here. Taken together, studies in humans have confirmed the U-shaped dependence based on baseline dopamine probed by each polymorphism. In this model, I haven't talked about D2. As mentioned before, dopamine in the striatum and the PFCs observe distinct roles of updating and stabilization respectively. One application of this model is that different functions require distinct levels of dopamine in different brain regions. What do I mean by that? High dopamine levels in the PFC might be good for stabilization, but bad for flexible updating, for example. Conversely, high dopamine levels in the striatum might be good for flexible updating, but bad for stabilization. Based on this, we might expect that the genetic variations that affect dopamine primarily in the PFC, but not in the striatum, such as the COMT variation, these might confer both behavioral costs and behavioral benefits, thus painting a slightly more complicated picture. All in all, D2 might also need to be taken into consideration to explain disparities in VALs and METs. Okay, so I explained a bit of the background regarding dopamine and function in the human brain. So what about dopamine and vascular structure in the brain? Dopamine has previously been suggested to have direct effects on the brain microcirculation and to underlie hemodynamic changes of many brain functions. In this respect, dopamine and dopamine-like drugs such as cocaine can induce dilations of brain vessels or increases in cerebral blood volume or CBV. More specifically, in a study by Kremer using light and electron microscopic immunocytochemistry, they showed that dopaminergic actions innervate the intraparenchymal microvessels. Axons immunopositive for dopamine, or the dopamine transporter, were readily found in close opposition to blood vessels in the frontal lobe, both in premotor cortex and in prefrontal cortex of rhesus monkeys. In another study by Choi and colleagues, they found that the D1 family included both D1 and D5 receptors may be more directly relevant to the control of the cerebrovascular tone. Specifically, in anesthetized rats, they found a relationship between changes in CBV induced by amphetamine and changes in extracellular dopamine measured using microdialysis. In addition, D1 and D5 receptors were the most frequently associated with a microvascular bed in regions responsive to dopaminergic activation. Finally, DA agonists increase cerebral blood flow and arterial dilation in primate cortex, as shown by early studies. Piggybacking a little bit on these later studies, DA agonists produced significant dilation of individual PL arterioles in the parietal cortex. However, what is cool about those studies is that D1 and D2 receptor selective drugs exhibited different dose-dependent relationships, whereas a D2 receptor agonist elicited a linear dose response, as shown here, in vessel dilation. D1 receptor agonists produce an inverted U response with greater dilation achieved at mid-range doses and insignificant effects at low or high doses. So given this evidence, we predicted that augmentation of dopaminergic signaling will have opposing hemodynamic sequences as measured by, at least at the beginning, cerebral blood flow. And these sequences will be triaged on the basis of differences in the baseline function. Speaking very simply, we sort of translated this inverted U model that was proposed before, and we disguised it in terms of hemodynamics and cortical perfusion. To sort of test this idea, we used a within-subject placebo-controlled design where we collected data from individuals stratified based on their level of baseline D1 and D2 dopamine using COMT and NAKK1 polymorphins in combination with action of two drugs with different dopamine effects. Tocopone, which is a COMT inhibitor, and bromocriptine, which is a dopamine agonist with preferential affinity for the D2 receptor. During each session, participants received a single oral dose of bromocriptine, tocopone, or placebo, and MRI data were collected. MRI data included resting state data, task-based MRI data, perfusion data that I'm going to talk about in the later slides, and also diffusion sessions. Behavioral data was also collected. Finally, PET sessions were also conducted where we measured FMT, that measures presynaptic dopamine, raclopride, that measures D2 availability, as well as raclopride with Ritalin, which allowed us to get an estimate of the amount of dopamine released. Diving into the methods a little bit more specifically, we end up with 82 healthy adults. 6 of them were dropped for the quality of the data. Out of these, 37 were COMT met homozygotes. As mentioned before, we had 3 MRI sessions, once each after administration of placebo, bromocriptine, tocopone. Out of the MRI data, of interest was to us the pseudo-continuous ASL sequence data. This is a sequence that can be used to quantify cerebral blood flow. We also had separate cognitive tasks to probe cognitive stability and potentially relate cognitive measures to differences in CPF. Diving straight into the data that came out of the study. So first, we analyzed the perfusion data from these individuals, and there were a couple of results. First, there were no simple effects of drug COMT genotype or NAKK1 genotype on gray matter perfusion. However, there was a significant drug times COMT genotype interaction. Specifically, changes in perfusion between tocopone versus placebo differed significantly between COMT METs and COMT VOTs, as shown by this figure right here. There was no similar effect when bromocriptine was considered. In addition, no effect of COMT genotype was observed during the placebo session. So all in all, we found that there was an effect in changes in global gray matter perfusion with the administration of tocopone, specifically for the MET versus VAL effect. To determine whether there were regions of the cortex that preferentially contributed to CMT-related variation in tocopone response, we conducted a voxel-wise ANCOVA with CMT genotype and age as predictors. Genotype significantly differentiated the delta perfusion within a cluster of voxels in the right inferior frontal gyrus. No significant clusters were observed in comparable analysis of bromocriptine response by CMT genotype. In addition, no regions demonstrated CMT genotype-related differences on placebo. This effect was not driven by outliers, and it was specific to CMT genotype, as shown by this histogram of the data of delta perfusion in the right IFG. So what does this data bleeds tell us about perfusion in these individuals? Speaking simply, we found that cortical perfusion following acute administration of 200 mg of tocopone significantly differentiated CMT MET, and VAL homozygotes. The direction of this was that perfusion tended to increase globally and more focally within the IFG in VAL participants, but to decrease in MET homozygotes. This interaction is consistent with the predictions of the inverted U model. Augmentation of dopaminergic signaling with tocopone triggers opposing hemodynamic sequences for participants on the basis of differences in baseline function. We further sought to relate the perfusion changes that we observed to behavior in order to see if these can recapitulate the sort of like standard behavioral effects that one would expect by the original inverted U model. We used task data from a task in which participants were trained to make either odd, even, or low-high arithmetic decisions on numbers appearing on the screen. Participants applied their dominant task rule when operating on digits appearing above the central crosshair, and the alternate rule when operating on digits appearing below it, as shown in this figure here. In some trials, when two numbers appear simultaneously, in both locations, participants were instructed to operate on whichever of the upper or lower digits was the brightest. If it was the upper, the brightest, you would ignore the lower digit and you would keep applying the rule. If it was the other way, if it was the lower, the brightest, then you would switch to the other rule. So in one case, basically you have a distractor. In the other case, you have sort of a switch cue. In this paradigm, one can quantify the distractor the distractor cost in terms of reaction time seconds that tracks the degree to which the simultaneous appearance of a salient but currently irrelevant stimulus increases the time required to complete the ongoing task. And this is kind of the interest that we're interested in, right? Because this metric can be interpreted as the extent to which participants can robustly maintain task representations in the face of competing information, a cognitive process that as I framed in the introduction, is thought to be affected by prefrontal cortex dopamine. In a previous study, we found a detrimental effect on distractor in METs, as shown by this figure here, with administration of tocopone, in accordance again with the inverted U hypothesis, i.e. tocopone impairs distractor resistance in MET homozygotes because these are the guys that have high PFC dopamine. We thus sought to see if this can be recapitulated with our perfusion data. What we found was that the mean delta CBF, this is the difference in perfusion between tocopone and placebo, across the IFG classes that we observed before, inversely correlated with tocopone-related delta destruction cost across the group and within the COMT met homozygotes, as shown by the figure here, such that poorer performance, aka higher destructor cost, accompanied reductions in perfusion. This correlation was specific to destructor cost, specific to that metric within task, and there were null effects, for example, with the switch cost when we were taking the switch trials into consideration. And also, the aforementioned effects were not present in other ROIs, so we couldn't find similar correlations in, for example, occipital control regions. To provide more evidence on the dependence of perfusion on baseline dopamine, we also utilize the FMT PET data. This is work in progress, but we have preliminary evidence, as shown by this figure here, that increase in CBF is dependent on the level of baseline dopamine synthesis in an inverted U-shape, aka if you have medium dopamine synthesis, then you'll have higher increase in CBF. If you're high dopamine or low dopamine synthesis, you'll have more attenuated CBF increase, which we think is really, really interesting, and we keep exploring. Given the changes in perfusion, we're also to see if these can be recapitulated in terms of hemodynamic lags. To do so and to maximize the available data for our lag analysis, we actually took the task fMRI data after removing the task regressors, i.e., we worked on the residuals of the task data from the task runs while keeping the noise in the data. Why did we do this? First, because the task data was more in abundance compared to the classic 10-minute resting state fMRI scans. And second, we also wanted to see if we can actually sort of apply this lag analysis method to residuals. At the single subject level, we found differences in hemodynamic lags between the three states. Our hope is to conduct voxel-wise and ROI analysis to see the regional differences in lags that are in accordance with our CBF results. General conclusions is that the inverted U-shape changes perfusion after dopaminergic administration that depend on baseline dopamine. These changes in CBF related to cognitive cost. We plan to look hemodynamic response via low frequency oscillation lags and potentially also bring the PET data into the picture. A more general conclusion that I like to propose out there is that these are really important studies in general for neuropharma fMRI studies. Why? Because there's a lot of variability in neuropharma fMRI studies that limits our ability to understand and predict dopaminergic modulation. For example, you might not have the right doses, you might have poor sensitivity, you might have the wrong task, or there might not be something like a U-shaped relation between dopamine and the relative cognitive dimension. Thus, we hope that addressing the physiological responses could be a new tool for better characterizing the nature of variability in dopaminergic drug responses, as well as the implications of such variability for cognition. Thank you very much for your time. I hope you enjoy the rest of the conference. And if you have any questions, my email is here. And thank you very much once again to the organizers and for having me talk in this conference. Thank you once again.
Thank you very much, Ioannis. That was very nice. I did have one question about your lag maps. They were kind of speckly. So I was wondering if you might gain some sort of detection power by doing maybe doing some ROI analyses, compare a region of interest to somewhere where you believe there's absolutely no dopaminergic effect.
Yeah, that's a good question. The lag map that I showed was basically one individual, and I think maybe some of the, maybe some of these results are going to be smoothed out as I'm sort of processing more and more individuals. But to be honest, when I started doing the lag analysis, I was mostly interested to see if it can recapitulate the sort of right IFG results that I saw with my perfusion data. And moreover, for various regions that have to do with sort of dopamine function theory, we're also interested in looking at specific ROIs, for example, the striatum and maybe the ventral striatum specifically, like the accumbens, like the nucleus accumbens. So I'm actually looking at ROIs as well that have been sort of predefined based on theory of dopaminergic function in the brain. So this is really preliminary, but we're sort of excited to see if there are any sort of hemodynamic differences between those ROIs and if these can change under direct dopaminergic modulations.
Cool. Ben, you had a question?
Sure. Let's see, two parts. First of all, the administration of these drugs, are they given orally?
Yes.
Yeah. And do you know if they have any other systemic effects? I'm just thinking, trying to figure. This is purely, presumably, being interpreted as a neural effect, right? So it's being uptaken through the blood-brain barrier or something. Are you absolutely sure that there are no other systemic effects?
We have so some of these drugs do change blood pressure, so we know that. And I just want to mention something that, when we're looking at this, so sort of most of theories of dopamine function have sort of have roots in sort of neural functions, right? So dopamine is considered basically primarily as a sort of underlying neural mechanism. But what we're looking at is basically to recapitulate these based on a pure physiology phenomena. So that can potentially interact with sort of what's happening neurally, but we primarily try to take a stance that if you sort of move away from the neural effects of dopamine in the brain, you also have these residual variants that can be explained solely by physiology changes, because, for example, dopaminergic receptors might regulate vascular tone or all those sort of things. But definitely we are keeping in mind that there are sort of trait differences when you administer those drugs in terms of blood pressure, and we're sort of trying to address these and take them into consideration when we're doing those sort of analysis. For example, bromocriptine has been shown to do that.
Okay. Given that we're a little behind on our schedule, I think we're going to move on to Arno and then move any remaining questions to the discussion at the end. Okay, so our next speaker, Arno Villringer. Dr. Arno Villringer is director of the Max Planck Institute for Human Cognitive and Brain Sciences in Leipzig, Germany, and a professor at the University of Leipzig and the Charité in Berlin. He studied medicine in Freiburg and did a fellowship at the Massachusetts General Hospital, then trained in neurology in Munich. He then moved to Berlin, where he became head of the Department of Neurology at the Charité before taking up his current position in Leipzig. He's a pioneer in perfusion imaging and optical imaging, as well as brain plasticity, mind-brain body interactions, and stroke. And I remember when I was doing a lot more nurse, I read an awful lot of his papers.
Hello, everybody. I am Arno Villringer, and I'm very happy to be with you here from a very hot evening in Berlin. A few years ago, or better, more than 30 years ago, in 1990, I was still a quite young scientist. I met a quite well-known professor who was specializing in stroke research. And I proudly told him, when I met him at a meeting, I'm planning to measure cerebral perfusion in patients with stroke. I developed some cool methods. This guy, however, was quite, nihilistic. He said, Arno, we know already well that in patients with stroke, cerebral blood flow drops, you do not need to measure it again and again. I have to say, I was a bit frustrated after this. Actually, I still continued my work. And I was reminded of this interaction when a few months ago, Ahmed, whom you all know, approached me and he said, Arno, actually, you know Ahmed, he said it much more, let's say, soft-spoken. Arno, I'm developing all these cool perfusion measurements. Do you think this is useful for something? And actually, this question of Ahmed was the reason why I'm giving this talk. Yes, the overarching question is the measurement of cerebral perfusion useful for something, of course, particularly in the clinic? So why should we know about cerebral perfusion? Why should we measure it? I will divide my talk in 3 parts. The one, obviously, the natural application is acute stroke. But I will also outline why even before, yes, maybe long before stroke, it can make sense to measure cerebral perfusion, and also that similar methods are useful in the assessment of recovery after stroke. So let's start with acute stroke. A very general question, what do we need to know in patients with acute stroke? You might say, oh, it's simple, diagnosing it. Actually, this answer is not perfect because the diagnosis of just a stroke is actually almost purely clinical. You do not need imaging to say, yes, this patient has a stroke. But you need any imaging? Yes, of course, we need to know what kind of stroke. The very simple and crucial question is it a ischemic or an hemorrhagic stroke? You can address this with MRI, ischemic versus hemorrhagic. Sorry, this is a CT, of course, but you can also address it with MRI. Yes, the answer here is yes, we need imaging to differentiate ischemia versus hemorrhage. And once ischemic stroke is diagnosed, what do we need to know then for guiding treatment? The obvious answer, which has become more and more relevant in recent years, now that we have treatments of stroke, the question is, does reperfusion make sense in a specific patient whom I am treating? In order to understand why it could make sense and why it may not make sense to give reperfusion or to do reperfusion, we have to understand the pathophysiology of ischemic stroke. Obviously, ischemic stroke is due to an occlusion of an arterial vessel, which supplies blood to a brain region. And what happens once such an occlusion has occurred, then within the affected brain region, certain areas, right here, are immediately or very soon irreversibly damaged. We call it the infarct core. And surrounding this green area is a region which still can be rescued. And if we don't do anything, the infarct core, the irreversible damage will increase at the expense of this penumbra. So the functional lesion we call penumbra, and the structural lesion red we call the infarct core. The problem is now that these pathophysiological events are very, very heterogeneous between different subjects. So maybe after half an hour or an hour, some subjects are already here. And maybe after 6 hours, 8 hours, some patients are only here or here. So in this situation, when still tissue can be rescued, it makes, of course, a lot of sense to reestablish reperfusion. However, at this stage, it does no longer make sense because we cannot save anything anymore. The only thing we can do is potentially lead to further damage to complications. For example, a bleeding as a complication. Now, most of the time, in many patients, we just don't know what's going on. We know it's an ischemic lesion, but we don't know about penumbra and infarct. And in the early studies of reperfusion, what one has done without knowing what's going on, one just went for a pragmatic solution. Basically, the pragmatic solution is if we do thrombolysis as early as possible, then it's likely that the patient is still in this situation. And this is the reason for the success of the early studies. For example, the first successful study, the NINS study, included many patients, I think more than half, who were included in the study within 90 minutes after stroke. And this turned out to be very crucial for the success of this study. And this was basically the initiation of the entire new way of treating stroke, no longer so new, but at the time of treating stroke with thrombolysis, tissue plasminogen activator, RTPA, which up to today is a very successful treatment. And you see here, at the time it was just significant when the patients were included within 3 hours after stroke. So there was a higher number of patients who went home with very little symptoms, 39% in the treated group versus 26% in the non-treated group. Now, in the meantime, many more studies have been performed, and we have some idea about the temporal window for reperfusion, which over all patients is successful. So after about 4.5 hours, we can say that if you just include everybody, then there is a turning point. After 4.5 hours, without any more information, we might do more harm than good to the patient. Before that, RTPA is used to treat stroke patients, even without knowing about underlying pathophysiology. Now, several attempts are being made to extend this time window, because 4.5 hours is still a lot of time, is still not a lot of time for the patients to get into the hospital, get an MRI to exclude a hemorrhage, and then get the treatment. So one way to improve on the situation is to define what they call a tissue block. So we know that a flare lesion only occurs about 4.5 hours after the onset of stroke. So if you have a fusion lesion but no flare lesion, then you can say this subject is probably within 4.5 hours. And so you can say, okay, then it's also the category where we can do the reperfusion. Even if the flare just seems to appear to be positive, this is still regarded as an early stroke and still a patient to be subjected to treatment. And in this patient where flare is already clearly visible, this is an older lesion, one would not indicate reperfusion. I should mention, these are images in patients where the lesion onset was not known. So this is what one does in patients who wake up in the morning and the stroke has happened somewhere in the night. And we determine via this tissue clock how long probably ago the stroke has occurred. And it has been proven in the so-called wake-up study very successful. The other approach is to try to depict penumbra and the infarct core in an individual subject. The way to do this is to identify the penumbra ideally as a lesion of perfusion, and to identify the infarct core as the diffusion lesion. This is the so-called operational definition of infarct core and penumbra. As I said, the perfusion MRI can tell us about the entire affected brain region, and the difference of this region to the infarct core, that is an operational definition of the ischemic penumbra, what we call mismatch. And this is how it looks in individual patients. This is a patient with a large mismatch, the fusion lesion, very small fusion lesion. Here you see the occlusion. And this is a patient where we would assume a large penumbra. The patient should get thrombolysis. This is a patient even early after stroke where the fusion lesion is as large as the fusion lesion. So you would not indicate or not put this patient onto thrombolysis. Here you see an example of a successful reperfusion. This is the initial MRI, and after 24 hours, you see that fusion has mostly recovered, and the fusion, the lesion overall has grown a bit, but it's by far not as big as it could have been given the initial size of the lesion. Now, these are individual cases. How is the overall evidence for this mismatch concept, the evidence for its usefulness? I think very convincingly in a recent meta-analysis, Guatemala has shown that if you either use a tissue clock or an assessment of the mismatch, and then you decide for treatment versus control. If you have an indication based on these two measurements, then treatment with RTPA is clearly more successful than in the control without RTPA. And this study was done in patients where the onset of the stroke was unknown. In other words, we can say that it's now very well established that either a definition of the penumbra or a tissue clock allows us to perform a thrombolysis reperfusion treatment. This is a subgroup analysis which shows that this statement is true both for the tissue clock as well as an assessment of the ischemic penumbra. And today, the recommendation is that based on the assessment of the tissue clock and the perfusion-diffusion mismatch, perfusion with RTPA is recommended in subjects with unknown time of stroke onset and with the time until 9 hours after stroke onset. Now, this meeting here is about not giving contrast agent, not doing dynamic susceptibility perfusion MRI, but rather to do non-invasive approaches based on endogenous contrast mechanisms. And as you know, one way of doing this is based on a time shift analysis. So you compare the resting state bolt signal to a reference signal, and then you assess the time shift, very simple, originally done by Yating and with Daniel Margulis. We were able to show that with such a very simple analysis, you could see this bolt delay shows very similar perfusion deficits as we were able to show with traditional contrast agent-based MRI. And we were able to show this in a total of 11 patients, and we could establish quite a good concordance between the two. Now, Ahmed came into the game, and he did the entire study much more systematically, very thoroughly, and he again could confirm a very close concordance between resting state bolt delays that you see here, and changes in either Tmax or MPT as assessed by traditional contrast agent-based MRI. And Ahmed also was able to take advantage of this non-invasive method to do longitudinal measurements. This, of course, is a great advantage of a non-invasive technique that we don't need to give contrast agents all the time with potential side effects. And also, we don't want to do repetitive contrast agent administrations. And here, Ahmed could very nicely show that you can identify patients where reperfusion has not worked with this simple technique, in this case, and patients where reperfusion has been very successful in this case. So now we have a methodology which correlates very well with traditional perfusion measurements, which is completely non-invasive, and which gives us as good as conventional perfusion measurements an indication of diffusion-perfusion mismatch. What are the next steps? Of course, we have to make it even more practical, and that's what Ahmed has been doing by developing these software tools that make it quasi an online, very fast tool. Another step is to combine such measurements with advanced metabolic assessments. I don't want to go more into detail, but with Otni Fan and Claudine Godin, Ahmed, and we were able to actually combine these measurements with a measurement of oxygen extraction fraction, which gives us an even more detailed assessment of the metabolic status that could even better define a region which still can be salvaged. Finally, we need more longitudinal and interventional studies to finally prove that we can do the entire assessment of patients with acute stroke non-invasively without contrast agent application and still provide a very valid indication for the type of treatment that should be performed. So that's the first part based on the acute stroke and the value of innovative measures of perfusion in this situation. And I will now, in the next part, move over to the risk factors. But I stop for now and come back in a few seconds. Hi, I'm back again to the second part of my talk. And as I mentioned, this will be about a situation before a stroke, or actually also before a dementia occurs. And I will mainly discuss about how a long path from risk factors leads to stroke and dementia. So why do people get a stroke? And why do people get dementia? As I already indicated, we know a lot of so-called risk factors. The main risk factors for stroke are hypertension, obesity, diabetes, and smoking. Interestingly, almost the same risk factors are there for Alzheimer's disease, hypertension, obesity, diabetes, and smoking. And only ApoE epsilon 4 genotype is different and specific for Alzheimer's disease. But the main risk factors are the same. And more we learn that also the path, the pathophysiological path is very much overlapping between the two. Another important point to make beside the same type of risk factors is the developmental path. We typically think of stroke like a bolt out of the blue. Patients will tell you, I was perfectly fine, everything was fine, and all of a sudden, boom, I felt very bad and I had a stroke. The same is true for dementia, or very similar. There, patients will tell you, I was fine. And then it started at some time point, and over the last year or so, I was rapidly getting worse. Now, do these risk factors actually act all of a sudden late in life? At this point, I have to also criticize a bit the term risk factor. With risk, the term elicits connotations like in the risk of stocks falling in price, the risk of being in a car accident, or the risk of getting lung cancer with smoking. In these situations, if the stocks don't fall, if you are not in a car accident, if you don't get lung cancer, then you're fine. So assuming a high risk for me in certain situations, if the outcomes do not happen, I'm fine. The brain, however, and the effect of these so-called risk factors is different. Let's have a look at the brain of a patient before a stroke or before the onset of the subjective onset of dementia. This is a typical MRI of such a patient. And what you see here, the white thing, is a diffuse damage to the white matter. And this is what you will see, or this a similar picture you will see in by far most patients at the onset of stroke. And this has developed over many years. In other words, we don't believe anymore that stroke or dementia come out of the blue, but they are the end point of a long path, and we assume this path lasts in most cases 30 to maybe 50 years. So the brain and other organs actually too are damaged long before the manifest disease of stroke and dementia. And the term risk factor is a misnomer. I mentioned already these risk factors: hypertension, obesity, diabetes, and smoking. And let me just have a look at two of them. This one you have already immediately understood, obesity. And here are numbers of obesity, for example, in Leipzig, but it's typical of Germany and worldwide. With increasing age, a majority of men and women will suffer from obesity. 70% of elderly women and 70, sometimes 80% of elderly men suffer from obesity. And the other risk factor, hypertension, very similar. In younger ages, there are less, but with higher age, we reach 50% and more of the entire population who will suffer from hypertension. Now, the picture that we have nowadays, how obesity and hypertension lead to stroke and dementia, is summarized here. And I will not go into very much detail, just give you a flavor of it. First, we assume that there are vicious, actually neurobehavioral cycles. So it has a lot to do with behavior that lead to obesity and hypertension. In parallel, brain damage slowly develops over many years, and finally patients develop a stroke, an additional large brain damage, or slowly progressive, they develop dementia. Let me briefly give you a flavor of the first part. In obesity, we and others have done a lot of research where we have been able to show that certain action systems, goal-directed versus habitual systems, are changed in obesity. What does it mean? So long-lasting factors, genetics play a role, but mostly environmental factors, eating behavior in childhood, chronic stress, food advertisements, and acute factors like acute stress and high fat sugar. They strengthen this so-called habitual system, which actually indicates the following: a vicious cycle. So the habitual system is associated with an elevated, pathologically elevated prediction of reward by food. This will lead to increased food intake, but, and that's the main point, this predicted reward is more than the one we get. And so we have a prediction error whenever we eat. So we are not as satisfied with food as we were expected to be. So, and in obesity, there is a reduced adjustment to this negative prediction error. And again, the prediction will be higher than the one that I will get. And this is associated with habitual behavior and lead to more and more increase in weight and obesity. And now, a similar thing, I cannot go into detail. This is a pattern of all the brain areas, especially areas that are involved in emotion processing like amygdala and insula, but also involved in stress processing that are responsible for the development of high blood pressure. And there's a similar vicious cycle. And this has especially to do with repetitive psychosocial stress, which leads to an overactivity of the central autonomous nervous systems via those cortical brain areas, a chronic sympathetic overactivity, which is associated with inflammation, endothelial damage, and again, an increasingly higher blood pressure response. And over time, this will lead to increasing resting blood pressure and hypertension, because this ever increasing higher blood pressure will damage vessels and lead to mechanisms that then are firmly entrenched in pathological vessel conformation and lead to higher blood pressure. And so if the vessels are stiffer, this social stress will lead to even higher blood pressure increase. And so the circle will continue at each level of higher blood pressure. So this is just to indicate the neurobehavioral cycles. Actually, it has obviously to do also with our societal factors. If you look in traditional societies, for example, there have been studies in Papua New Guinea in traditional societies, there have been no obesity and no hypertension. Most likely, this has to do with our lifestyle. But now, how does the progressive brain damage occur? And which role does blood flow play in there? This is well examined for hypertension. We know that with hypertension, vascular remodeling occurs. With hypertension, there is a chronic inflammation, blood-brain barrier will disrupt. And also with hypertension, due to these factors, there will be a slow decrease in overall cerebral blood flow. And this decrease in cerebral blood flow will go along actually via, interestingly, not neurovascular coupling, but vascular neural coupling. This will lead to a decreased baseline function of neurons and will lead to early cognitive decline. In other words, hypertension, when it's becoming longer lasting within years, will lead to a disturbance of the interaction between neurons, glia, and the vessel, and to a slow and ever more pronounced decrease in cerebral blood flow. Now, if hypertension eventually is a major risk factor for dementia and of course also stroke, then one would predict that this blood flow decrease may be an early step in Alzheimer development or in other forms of dementia. But that's of course counterintuitive if we think of what we typically think of Alzheimer's disease as a neurodegenerative disease, which is related to deposition of amyloid and other protein aggregates. So the question is a decrease in cerebral blood flow an early or late sign in the long path towards stroke and dementia? And actually, in very nice work by Ituria Medina from the Evans Group in Montreal, based on thousands of studies where they obtained information about amyloid deposition, glucose metabolism, blood flow, neural activity, and structural properties. What they consistently found is that the earliest changes, the earliest abnormality, this is time, and you can see here when the blue disappears, the abnormality is occurring. The earliest abnormalities seem to occur actually in vascular factors, not in metabolism, and even amyloid comes after the vascular factors. And you see here also a model time course. Again, the orange line, the vascular factors, the decrease in blood flow seems to be the first event that occurs. And that's actually a perfect link to those risk factors, which also lead to a decrease in blood flow. And most likely it's this decreased blood flow that is a major factor in mediating the slowly progressive cognitive decline. So a decrease in cerebral blood flow is an early warning sign for progressive brain damage, a crucial step on the long path to stroke and dementia. So this step, actually, where you see white matter lesions here, before they occur, we have to assume that there is already measurable decrease in blood flow. And now I come back to all your efforts to measure cerebral blood flow with non-invasive techniques. Of course, in order to depict such early changes, we need non-invasive techniques, ideally without contrast agents with potential side effects. So what we need now is to assess blood flow in people with hypertension, obesity, and smoking who are on that path, and already ideally very early in their life, because we have a lot of indication that these changes occur already early in the 30s and 40s of people who otherwise are completely healthy. We must perform longitudinal studies, and if we find decreased CPF, we may use this as a proxy for early, very aggressive intervention, maybe much more strict blood pressure control, much more strict obesity, fat control of blood cholesterol and metabolism in order to intervene when the CBF has not yet led to changes in brain structure and to irreversible brain damage. So, my point in this part of the talk is that thorough and precise measurement of cerebral blood flow is not only relevant in acute stroke, but also as a preventive biomarker to guide our preventive treatments and to prevent, in the end, early occurrence of stroke and dementia. So this was my second part, and I come back soon for my third part. Welcome to the third part of my talk. In this part, I will discuss how blood flow measurements and specifically functional connectivity measurements will contribute to our understanding of symptoms after focal lesions and stroke and recovery of symptoms. When we think about what determines symptoms after a stroke, one could think that it's the type of lesion, hemorrhage versus ischemia. The answer is not really, or very little. It's much more important to look at the location of the lesion and the size of the lesion. We know from several studies and clinical experience that location and size of a lesion correlate with the type of symptoms and also the severity of symptoms. However, we also know from clinical experience that quite often the same location of a lesion goes along with very different symptoms, or different types of locations go along with very similar symptoms. And systematic studies have clearly shown that location and size, while important for explaining symptoms, explain only about 30 to 60% of the variance. This is also illustrated when we look longitudinally at the time course after a stroke. Within a few days, symptoms change. Lesion size and location are the same. However, significant functional recovery can occur. And obviously, these changes must be related to changes outside the lesion. And we assume they are related to connected brain areas. This idea that symptoms are related to connected brain areas goes back to a quite old concept of diachesis. This concept of diachesis has been put forward by Constantin von Monaco, a neurologist in Zurich, already about 100 years ago. What he noted is that symptoms depend not only on the location, but also on those brain areas that are connected to a lesion. So what he found, or what he said, and how he defined diachesis is a loss or change of function in a portion of the brain connected to a distant but damaged brain area. He also noted already that diachesis is time dependent. Now, if diachesis depends on the changes in a functionally connected region, then it's straightforward how to assess diachesis after stroke in modern times. Now that we have resting state fMRI, which allows us to examine functional connectivity, pioneered by Biswal, and he already noted that connectivity maps that we get from task-free fMRI closely resemble maps that we get from task-based MRI. And in first studies, single networks or single connectivities were examined in patients after stroke. And in this study by He et al., a pioneering study, they noted that there was a strong frontoparietal connectivity network in healthy people. This was destroyed, the connectivity was destroyed in a neglect patient. And when the patient recovered from the neglect, then also the correlation between the brain regions, the connectivity would recover. This idea subsequently was extended from single networks to multiple networks. So, for example, Beckman has identified 8 quite strong networks, which we and others have used as templates for studies in stroke. So in these studies, we classified those 8 networks in healthy volunteers, but also in stroke patients. And in the stroke patients, we identified those networks that were affected by a lesion because the lesion was inside that network, and those which were not affected by the lesion. Then we followed those patients over 90 days with several resting state fMRI measurements. And then we checked whether we could distinguish between those networks that contained the lesion and those which did not contain a lesion, and whether this distinction would have an impact on the symptoms. And indeed, to make a long story short, that was the case. We were able to show differential connectivity changes in affected versus non-affected networks, and we could show that this relates to the change in symptoms in the time course of recovery. Now, this approach was still based on looking at the brain as if it were to contain distinct, separated networks. Of course, it's not the case. Also, different networks also are related to each other. So obviously they are not separated, but there's a communication of everything with everything in the brain. So is there a more parametric solution which considers that fact and which considers all brain areas? Yes, there is. As you probably all know, a different way of looking at the organization of the brain has been put forward by Daniel Margulis in the last 5 years, when he showed so-called connectivity gradients. By non-linear decomposition, he could represent whole brain connectivity in lower dimensional space. And by doing this, he identified several distinct connectivity gradients, which explained principles of functional organization. And each voxel can be located along a certain gradient according to the similarity of their connection. So, for example, the most pronounced gradient number 1, so to speak, has on the one end primary sensory and primary motor area, and on the other end, the default mode areas. And this is kind of a major organizational principle in the brain, and other gradients basically explain other organizational principles in the brain. And now, can we use this organizational map in order to better understand reorganization after stroke? That's what we systematically tested. We tested the impact of a location within a gradient on symptoms after stroke. We looked especially at the first 3 gradients, according to Daniel Margulis. And to make, again, a long story short, we were able to show that the distance within a gradient, the distance to the lesion, was a very good predictor of symptomology of stroke patients. And this was actually interestingly true not for all gradients, but especially for gradient 1. We don't fully understand why it's just relevant within those 2 gradients. This could be due to maybe we had a relatively small sample size still, but it could also be due to organizational principles that are reflected by these gradients. And obviously, this is a fascinating area of future studies. In larger sample size, I should mention that there was also a correlation with the clinical scores according to the distance from the lesion within the gradient. And what we can conclude from that kind of study is that we can conceptualize the impact of lesions on brain connectivity within a continuous connectivity defined space. And what I have now shown you is how one moved, our community moved from looking at the connectivity between two regions to networks, to many networks, and then to an entire parametric connectivity space. And it seems that we can ever better explain symptoms associated with focal lesions and stroke. Another way to look at the impact of lesions is to differentiate between so-called connectors and hubs. And the idea is that hubs affect a certain area when they are lesions, whereas connectors, when they are lesions, might have an impact also on adjacent networks. And this is what Clapton et al. Were able to describe. They indeed were able to show that lesions to connectors led to widespread decreases of modularity, and lesions to hubs had only a more localized impact on function. And the final way, a final study that looked at the relationship between symptoms after stroke and connectivity is an interesting study by Corpetta's group. They looked at the question that I mentioned in the beginning. So is it more a location, or is it more the connectivity of a lesion which determines symptoms? And what they found is quite interesting. So I mentioned in the beginning that the location explains some variance and the connectivity explains additional variance. And Siegel et al. In this nice paper showed that it seems to be differential depending on the type of function that you're looking at. So attention, visual memory, so higher cognitive function, were affected when functional connectivity was considered, whereas motor and visual function were much better explained by the lesion location. So in conclusion, resting state functional connectivity captures functional recovery after stroke. Approaches based on single network, multiple networks, connectivity gradients, and machine learning have been successfully applied. Hubs and connectors seem to have specific effects, and functional connectivity explains additional variance after stroke, especially for higher cognitive functions, except language. And other functions like motor and visual functions seem to be better explained by the location of function. What are the next steps in this area? I think it will be important to elucidate behavioral significance of connectivity changes. For example, one can start with large databases and relate them to structural connectivity. Prospective studies are needed on network reconfiguration in stroke patients starting at the subacute phase. Little data are available on the subacute phase. And in the future, I think these connectome fingerprints will be ideal starting points for non-invasive brain stimulation, which also addresses connectivity, but as a treatment approach. So these assessments of changes in connectivity will be ideal, the ideal pathophysiological underpinning for treatment approaches in the future, especially in the chronic phase after stroke. Let me finally thank those people who have contributed to this work. And I start with Ahmed, who has been involved in all of these studies, Yatin, Smada, Daniel, Audrey, Claudine, Jochen, Shema, and Kirsten. I thank all of them, and I thank you very much for your attention.
Thank you very much. That was a great talk. I have a question from one of our panelists first. Ioannis.
A great talk, and it's very close to one of my research directions because I'm also running a stroke recovery study where we're also scanning veterans that had stroke longitudinally. So it's something that's sort of close to my research interest as well. And I think my question sort of relates to the latter part of your talk. And, when we talk about stroke recovery, a lot of people sort of pull all of the, pull a lot of stuff into this simple definition. It can be motor recovery, it can be language recovery, it can be, and one sort of striking thing to me, and I think you mentioned that in your talk, was that, network organization, this sort of high order plasticity, can explain some of these, but not others. Why do you think that is? How that relates sort of like the network organization? That's my first question. And the second question basically is, if we think that there is sort of this underlying network organization that's responsible for recovery, do you feel like that, for example, lesions in different parts of the same network would cause, would have similar impacts to recovery? For example, in the motor network, if you have an M1 lesion versus a cerebellar lesion, and whether that's sort of going to have the same deleterious effect and sort of recovery trajectory effect in the long run. So thank you very much.
Yeah, thank you very much for this. Can you hear me? Can you hear me?
Yep.
Yeah, okay. Yep. Thank you very much for this question. I think the picture in reality is, of course, much more complicated than, I apologize, this was a very didactic talk, actually. So, and I also saw that that Ahmed covered several of things. Now, I think that networks contribute to symptoms is one aspect, but not the only one. So for example, in contrast to many animal studies, we are looking at patients who have a long history of diffuse changes in the brain. So that's the first aspect that is very often not considered and is very important for recovery from stroke. Then also, yes, if you have a lesion within a network, you tend to have similar symptoms, irrespectively of where in the network the lesion is. However, this may have profoundly different impact for the recovery. I mean, for example, if you have in the motor system, if you have a dissection of the corticospinal tract, you can do whatever you want. You will not recover motor function well. So there are clear cases where certain lesions just cannot be recovered, and other parts can be covered much better. And generally speaking, I think this problem is the lack of specific recovery is more pronounced in primary areas, like in the visual system. If you have a lesion in occipital cortex, you will not. It's very difficult to recover visual function in that area. And in more in associative areas, higher cognitive areas, you have more room for compensation. So I think all these factors, so like systemic factors covering the entire brain, local factors, and networks factor all contribute to recovery, and that makes it so extremely complicated. And that's why overall, yes, of course, we all show, and I did also certain examples, relatively small sample sizes, but you have to do both. You have to be very individual, and you have to, if you want to understand specific effects, you need large sample size, and then post hoc group according to very similar entities. No? And also in treatment, we probably have to address all those things. I think so regarding the network character, I think transcranial stimulation approaches specifically targeted at disturbed networks are very promising. Combination of functional connectivity, MRI to target brain stimulation. We need methods to address overall changes in potential of plasticity, probably drug-based, and in those type of lesions, as I said, in corticospinal tract, if that is gone, then you need, I don't know, an invasive implantation of some bridge anti-no-go treatment like Martin Schwab does. So I think for different people, we might also need different approaches.
Absolutely. Things are very complicated indeed. We see it in our data as well, but thank you very much.
Okay. I'm sorry, yeah, I have another question here. I just want to remind people that this is a section on clinical studies. When comparing resting state functional connectivity fMRI results between groups, is it recommended to add measures regarding vascular health and vascular related scores as covariates?
Could you just repeat? I just didn't hear you well.
When comparing resting state fMRI results between groups, is it recommended to add measures regarding to vascular health and vascular related scores as covariates?
As an overall, I mean, this actually goes precisely in the direction of systemic factors and more localized factors. I would depends on what you mean with an overall vascular factor as covariate.
I'm not positive comparisons are relevant in individual diagnostic tests, but
in individual, I think it's probably not possible. If you have large groups and you want to tweak out certain effects, you might look.
Yeah, one simple example is, for example, if you look at the resting state fMRI differences, you probably need to sort of take into consideration the differences between the underlying hemodynamic lag differences, maybe even if you have good diffusion data, maybe looking at differences in, if you look at motor cortex lesions, the underlying CST fidelity and all. So definitely there are some covariates that you need to take into consideration when you.
Okay, so a certain delay if you have a cardiac stenosis, so that of course is something.
Exactly.
If you have, I understand. Okay, if you have, like, let's say, a cardiac insufficiency, you should take that in. These kind of things are definitely, yes.
Ben has a question. There's also a question from the chat, which I think is a nice sort of summary question to all panelists. Taking all of the presentations regarding hemodynamic noise into account, using functional connectivity as a measure of neuronal communication seems risky regarding false positives. What are your opinions about the issue? Anybody want to field this?
Can I have a go at that?
Well, a hemodynamic artifact? Okay, I've said it. So
can I have a go at that? So so I think, as I mentioned before, I think we don't know enough to be able to say kind of how big of a kind of problem or an issue kind of is this for people who are looking at mostly kind of the functional organization of the brain. It's clear that it's something that's influencing the data. It's something that can help, that can interfere with your interpretation of functional connectivity. And so my strategy so far has just been like, if you're dealing with kind of a patient population that has some kind of gross vascular pathology, like stroke patients, for example, then maybe you're doing some kind of functional connectivity analysis or something that's good. Do that, and then make at least an attempt to deal with for example, with the hemodynamic lag. So try to denoise the data in a kind of lag-based way, and then rerun your functional connectivity analysis and take a look at what you get and just compare those. I think that's kind of in my opinion, that's kind of a good starting point just to help us understand a little bit more kind of what's going on.
Yeah, and I think I think there's real evidence that hemodynamic or that neuronal connectivity is a thing, but the fact that I think, as we've seen from a lot of the talks that we've had over the last 2 days, everything's more complicated than you want it to be, and biology is never one thing or another thing. It's usually some mishmash of various things that just sort of happened. So I think we can get neuronal connectivity out of functional connectivity, but we have to be very careful about thinking what we're doing. And I see what Ben and Ravi both have their hands raised.
Yeah, I'll be quick and Ravi can jump into. My concern is actually more on the false negatives side. Going back to the clinical, if you've got a patient, Ahmed and Arno, maybe anybody else with clinical training, we develop tools and then you have to deploy them. I'm curious, how much time are you prepared to commit to these methods? Is this something that you think, what are sort of your criteria for rolling this out to other hospitals, making it a new standard of care so that we get some feedback, just in case we're barking up the wrong tree? There are other MRI methods I know out there, T1-Row, Aristokalpanin, Ali Groen has been looking at that. So there are other acute measures. In chronic stroke, you've got all the time in the world, but in acute stroke, if you're giving us 3 minutes, 2 minutes, we've got to spend that really, really wisely. So I'm curious to know what you think our specifications should be.
It should be fast. It should be simple. And I mean, in acute stroke care, you see that people are still using mostly CT just because it's fast and it's available all the time. And I think these are criteria often forgotten when you develop new techniques. So for something like bolt delay and MRI in general, you just have to be extremely fast. You have to be accessible. I can tell you, if you are not 24 hours a day accessible for acute intervention, you will not be used. And these things are often more important than fancy pathophysiological information. So as an MR person, I have to observe that CT is still winning over the acute patients, I guess almost everywhere. I mean, at the Charité, I once bought a MR system on the stroke unit, and still in most patients, they do the CT first. So, but it's not, things are catching up, and a technique like bolt delay, and if you have a fast assessment, I think things could turn, and especially for example, in the late patients, so the 4, 5, 9 hours patients, there I think the picture is a bit turning towards MRI if you have it available.
Thanks.
Robbie?
Yeah, so Arno's point was made quite clear to me just a few weeks ago when I was talking with Franz Schmidt, who some of you know at Siemens, retired, but his father had a stroke and he had taken him into the hospital and they put him on the CT scanner couch, and he was asking the X-ray tech, so when are you going to start the procedure? And the X-ray tech said, we're done. And so in the time it takes to do a pre-scan on an MRI and get your grappa, or your sense, or your fleet, or whatever calibration things, let alone B0 or anything else, CT was done. And until you can do that with MR in the acute scenario, I think you're going to be behind. But in the chronic scenario, when you do have time, so at the point of reperfusion or when you're assessing stroke recovery potential, then in those situations, sure, you can spend 5, 10, 15, 20, 30 minutes to assess whether, the ipsilaterality of a network or some other index that you want to use is going to be indicative of potential recovery or something. But in the acute case, where every second counts. Now, most of the time you're not dealing with acute stroke because most strokes don't happen in the hospital. They happen at home and you don't actually know when the clock started. And I think Arno's talk was very important for trying to assess damage when you don't know when the clock starts. But even there, you want to be relatively fast at that point. But coming back to the original question about resting state functional connectivity. Well, I mean, of course, we don't measure functional connectivity. If you do electrophysiology, like I do in monkeys, then you measure connectivity by putting electrodes in a couple of places and doing antidromic stimulation and things like that. And that's how you establish connectivity. All we measure are correlations. And so if you have vascular fluctuations, you get correlations. If you have neuronal correlations, fluctuations, you get correlations. Basically, anything that fires or flows together will give you correlations. And so that's the problem. And how do you separate these? Well, there are certain temporal characteristics that may or may not be important, because vascular and neural responses can be a little different. I think Jean Chen suggested a few ideas. My more recent thinking is, if you look at the phase data, anything you see in the phase data, you don't want to see. Anything you see in phase is motion, it's breathing, it's a large vessel, it's flow. The only thing you don't see in phase data is capillary signal. But how you use the phase to remove those confounds is a trickier problem. But maybe that's one possible way to go about this. But yeah, I mean, so it's not connectivity per se that we're measuring anyways. And I think we have to be really careful about claiming that.
Joe, you have your hand up.
Yeah, thank you very much for that talk. Fascinating. So the stroke and the dementia is basically a threshold disease. You approach it, and then you fall off the cliff at the end. So with 30 years of approaching the cliff, do you have any sense of what kind of studying we can do to identify, like some people are going to approach it faster and more certainly than others. Some people are obese and smoke all their life and they still die without any of those. And some people catch them early, So we have so many people that are on that trajectory. Is there anything that we can do, any information that we can get before they fall off the cliff that will help us monitor their progress, or give us a biomarker for intervention and be able to monitor it if we do intervene, and this kind of thing? That's the question.
Oh, we have a number of clinical biomarkers. So ultrasound assessment of carotid arteries, intima media thickness, plaques in the carotids is one indicator. The amount of white matter lesions is another indicator. I would argue that a measurement of cerebral blood flow is yet another to be, of course, established indicator. And if you are fine with all those indicators, if somebody is 75 and has no white matter lesions and has normal cerebral blood flow and no calcification in the carotid, then I think you have very good chances not to suffer from a stroke, and then you are less advanced.
What about the connectivity, though? Would that help?
Good question. I don't know of any systematic study that, we know that early Alzheimer goes along with reduced connectivity of the default mode network. We know also that patients with hypertension or patients also with severe obesity for many years also have reduced connectivity in the default mode network. it's another unspecific sign, actually probably a rather late sign, which correlates with the other factors. All these factors that I mentioned are not very specific, but putting them all together can make you confident that somebody is on which side of this path somebody is. What we are still missing is like a clear, let's say, parametric assessment, like an overall score. But that's something which I think also with, I mean, there are other machine learning based things like brain age determination. Which basically, if you feed the machine learning with all these parameters, maybe also other clinical parameters, what we already have been able to show is that your brain age and the difference between your brain age and then your chronological age is another indicator. And if you take all these, and this indicator actually correlates with cognition, with memory performance, and also correlates with the presence of risk factors. So of course, this is always statistics, but if you take, so many parameters are being developed, and taking them all together, I think we are approaching precisely what you are asking for, an overall assessment of where we are on that long path.
Okay, I'm going to take one last question from the Q&A, and then Jean had her hand up, and then I think we should start to wrap up. Okay, so thank you for your great talk. I'm wondering if resting state frequency responses were altered when resting state functional connectivity was recovered after stroke, compared to those normal subjects. For example, reduced power of resting state signals, less resting state frequency peaks from 0.01 to 0.1 hertz, and so on.
Was the question to me?
Yeah. Well, I think it was
again. I just there is some problem with my microphone. I'm very sorry. Could you just say it again?
Yeah. Thank you for your great talk. I'm wondering if resting state frequency responses were altered when resting state functional connectivity was recovered after stroke, compared to those of normal subjects. For example, reduced power of resting state signals, less resting state frequency peaks from 0.01 to 0.1 hertz, or so on, and so on.
In our study, we did not systematically assess this, so I cannot tell you. I would assume that some of them have recovered, but I cannot give you a specific answer because we just didn't look at those parameters.
Okay, Jean, did you still have a question? Or?
Well, I see another question from the attendees just popped up. So would you like to address that?
Okay. For any panelists that deliver CO2 to research participants, increased CO2 is generally well tolerated by participants. However, there still seem to be a large variability in how subjects respond to CO2, i.e. some people notice the CO2 changes and have strong physiological changes, e.g. in heart rate, and some people don't notice it at all. I do have a clear, one, do we have a clear understanding of why? And two, is this variability biologically interesting? I was just speaking for myself, having done some of these experiments. We did find that certain people became quite uncomfortable when we gave them a 5% CO2 stimulus. They got all hot. Certainly the respiration rate increased. Other people didn't seem to notice. Anybody else?
So from my personal experience delivering 5% and up CO2, I had a friend and colleague who was a musician, and we could not get a bold response from him with the hypercapnia. So that is something, maybe if you were to scan that person, you would just not see as much response. And it is a natural part of the variability.
I wonder whether that tells us something, though. I mean, you just need to know what the biology is, but it certainly could be informative, that individual biological variability, if you could put your finger on what was the causative thing. I certainly remember in the early days when I was a postdoc in Minnesota, so this is now 30 years ago, Seiji Ogawa would show no bold effect, you know, even with grass goggles flashing at full strength. And he blamed it on the fact that he was a smoker. And then his brother had a stroke, so he stopped smoking. And much later in life, I believe he started showing a bold effect. So, you know, these kinds of complications could be quite interesting, I think, if we could understand them, and we can't always do that easily, I think.
We've studied about, I would say, between 2,000 and 3,000 patients and healthy subjects and so on. We haven't looked systematically at it, but I can give you some comfort in knowing that this is something to do with the chemoreceptors in the brainstem. And there may be, and it's not necessarily that it's connected to any other physiology. We haven't noticed, at least I haven't noticed, any systematic correlation between sensitivity to CO2. When we do healthy people, they all seem to be healthy, and they all seem to have no other conditions. And some of them, you raise their PCO2 by 3 millimeters of mercury and their eyes bulge out, and you know they want to press the button. And other people are quite happy to lie there and have their PCO2s up into the 60s for 15 minutes. And then, you know, they're not happy, but, you know, they're not totally stressed out. We haven't noticed any difference. There's some question as to whether people with steno-occlusive disease and limited blood flow are more sensitive to the CO2, which may be possible. Yet still, we raise everybody's PCO2 by at least 10 millimeters of mercury, and they all survive without pressing the button, including those with a severe disease. So, like, I'm not sure. I think if we looked at it very carefully, we might see some correlations, but they're not going to be extremely strong because most patients, we have about 93+% of the patients who undergo their CVRs, and these are all comers, all referrals, undergo their CVRs with successfully. So
there may be another component to feeling uncomfortable when you have CO2, which could be just the sensitivity or your ability of interoception. So we have been studying this in counting your heartbeat, for example. And so there are very pronounced differences in interoception, which relate to the activity of the anterior insula. So some people have a very strong sense and are very sensitive, and others don't. I don't know a specific study with sensitivity to hypercapnia, but I would assume that it could be along those lines. And then if that were the case, then it would have nothing to do with any cardiovascular risk or anything, but it's more on the psychological side of things.
Yeah.
Would be interesting actually to study this more systematically. In the extreme cases, it is actually related to psychiatric disorders, anxiety, panic disorders,
yes.
And
panic disorders. That's right.
As you know, these are the extreme cases, but there is also a great variability within healthy subjects, which are more or less sensitive. I would think it's related to this.
There's also a physiological effect. So if you allow them to take deep breaths, at the end of the deep breath, they get relief, and they don't get stressed again until they exhale. And then they're stressed, and then they take another deep breath, and the stretching of the spindles gives them relief. So some of them get through on that basis. Also, we have a little study going now to see if we increase the baseline PO2 to 150 instead of 100, is the distress less? And so we're looking to see is there a difference in the CVR that we notice? And since we can clamp the PO2, so if you don't clamp the PO2, the actual PO2 varies with the minute ventilation, even if the inspired PO2 is constant. So, so as they breathe harder and harder, their PO2 goes up. But with our system, we can clamp the PO2, and we can look at the CVR, just changing the CO2 at 2 different PO2s. So one of our graduate students has a side study for her thesis is collecting these, and we may be able to report what we find.
Can I just jump in? So I'm going to switch my question. So related to that, in Toshihiko's talk, he's shown that we have a very fine sensitivity to O2 in the lags that we measure even in normal brains. And then there's the lack of lags detectable when you've got myon. So when you wipe out the bolt, suggesting that the oxygen is key to being able to detect anything. So in that case, might we be barking up the wrong tree? I wonder if we might want to actually manipulate the oxygen and use that more as the stimulus. We can still use the CO2 for vasodilation, but maybe do something, could be linear, could be more stochastic, but maybe driving that system would give us more power. We might be assuming everything's CO2, but CO2 may be modulating the O2. That's the O2 that's actually giving us what we're measuring.
Yeah, so I think that variations in O2 between normoxia and PO2s of about, let's say, 50 down to 50, possibly 40, you know, so let's say 50, so between 50 and 100 PO2s in that range probably have very little effect on either cerebral blood flow or respiratory drive of any kind. And that's maybe bad news, but I think it's also good news. The good news is that, as you just said, I think what you said is very important. Since you can detect the difference in the oxygenation on the hemoglobin, if you vary and cycle or just step or change your PO2s and change the deoxyhemoglobin, that gives you a signal about that you can derive cerebral blood flow, MTT, and other information from without actually affecting what you're measuring. With the CO2, you have a stimulus and response. So you're actually affecting things, and then you're looking to see what happens there. You know, you have a ping and you want to see what happens. With O2, you can use any ping you want and use the O2 as your contrast to see what is happening. And that's what we're looking at right now. I didn't include that in my talk earlier because, you know, it's like another topic, and in 30 minutes, it's hard to add these things.
Okay, I'm going to have to step in here. We're going to, we have a final question in the Q&A, and then I think we're going to have to move to closing remarks because I know we're keeping a lot of people up way past their bedtime in a lot of different time zones. So let's see. So
it's my fault. I just wanted to see Ravi's answer to that one. That's why. Sorry about that.
Oh, well.
Sorry, I'll just read the question so people hear it. For Ravi, you commented on using the phase to remove these vascular effects. Don't you think that this will remove CVF changes of interest?
Well, yes. So if you want to see CVF, then the phase will help you identify CVF, but you certainly don't want to regress it out in that case. Yeah, you have to use it judiciously.
Okay, so I think we had a really good 2 days. Things are not quite over yet because tomorrow there is a software workshop at same starting time as the day before, but we do not have a second session tomorrow. This is available to all attendees at a small additional cost of nothing. So we certainly hope that everyone can attend. Sort of summing up the workshop, I think we saw a lot of really cool talks, and I think sort of the take-home message of all of them was that BOLD is complicated, and I think every time we learn more, we kind of think, oh, that we're going to do the next experiment, we're going to do the next technique, and it's going to show us that BOLD is much simpler than we thought, and we can learn all of these things about the brain. And I think the answer is no. Every time we lift up a rock, there's another hole with more rock. Well, that's a terrible analogy. Anyway, I think every time we look deeper into fMRI and we learn more about it, and we think we know more, we do, but we also have learned how much more we don't know about physiology, about the vascular effects, about all kinds of interconnected system, about how neurons affect physiology and vice versa. But I think I think the kind of stuff that we're doing here, the kind of stuff we're talking about, is important to understanding what you can and can't learn with BOLD. And I think we've the net result of all of these new techniques is that we know a lot more about humans than we used to, humans and animals. We've learned things about physiology when we thought we were looking at the brain, but we've also learned about the brain. So I think, I think we should carry on with this sort of work. And I think, as I mentioned earlier, we would really like to do this again sometime. I had a lot of fun. And I think I got to see a lot of talks that I wouldn't have seen otherwise. And I think this is a topic that is big enough and interesting enough to enough people that I think having a dedicated, symposium is a good idea. So we'll, if anybody has any ideas for how we could do this better next year, I think one of the things that I think we would like to do is increase the time for discussion, because I find that that's the most interesting part. And I think even though we went over time on all of the sessions, I felt like we had to cut the discussions off sometime, and I would have liked to have more discussions. I'd also like to see if we could add some sort of social aspect, maybe even a virtual social aspect like GatherTown or one of those sorts of things. Ideally, we'd all end up in the same place someday, but I think realistically we can't plan for that quite yet. And I think again, if we do this again, I think I think it's important that we maintain the virtual presence as an important part of the meeting, and that virtual attendees should be first-class attendees. Because I don't think. I think we've shown that you don't really need to miss out on anything if when you design the symposium, you sort of think about how to involve people from all over the world. So anyway, if any of the other panelists wanted to say anything, I think thank you for coming, and I'm done.
Yeah, just a big thank you to everybody. I guess this was our sort of first attempt to organize this, and yeah, it's been a big effort for all the people that were involved, and just want to say thank you to everybody, to obviously the organizers and my friends that were sort of kept pushing for the past year to make this happen, and to the panelists, everybody that joined. And this is not the end. We're sort of hoping to do this next year. We also have the Slack channel for sort of more of a continuation of research talk if you guys are interested in. And yeah, just a big thank you to everybody.
And we may pick on a few of you and drag you into our regular Tuesday morning meetings, so we can have like joint lab meetings. That's been proposed by a couple of different people. So expect to get pinged directly, so we can get more of a sort of a two-way conversation rather than a big group thing going.
Okay, well, it looks like we're winding down. So again, thank you all for attending. It was great to have you all, attendees and panelists, and to the speakers, thank you so much for all of the work you put in to make really excellent presentations. And don't forget, tomorrow, same starting time, there is a software workshop. Everyone is welcome.
Thanks, everyone.
Thanks, everyone.
Thank you so much.
Yeah, thank you,
Thank you very much.
Bye.
Bye.